everyone, and welcome to the 11th Annual Global Health Symposium. The title of today's symposium is Ongoing Challenges Around COVID-19. I'm Jean Witowski-Wendy, the Dean of the School of Public Health and Health Professions. Every year, the School's Office of Global Health Initiatives organizes this Global Health Symposium and invites experts to present their work on topics with global health significance. As the COVID pandemic continues to threaten our communities and the public health worldwide, we are having increasing concerns about things like long COVID, mental health issues, community health, and the environmental impacts. We are grateful to have experts from the World Health Organization, the National Institutes of Health, academia, medicine, public health, and our community with us today to discuss the ongoing challenges around COVID-19. We hope that this symposium provides an interdisciplinary forum for discussion about the next stages of our response to this pandemic. Dr. Lena Mu, Associate Professor in the Department of Epidemiology and Environmental Health and the Director of the Office of Global Health Initiatives in our school, will now tell you a little bit more about today's event and will introduce our speakers. Thank you again for joining us today. Enjoy this conference and happy Earth Day to everyone. Dr. Mu?
Thank you so much, Jean. I would like to welcome you all to our Global Health Day Symposium. This is our 11th year organized this Global Health Symposium to address various important global health issues. So in the past, we have discussed substance use, the climate change, early life exposure, women and children health, so on and so forth, many important topics. Today, we'll try to discuss several challenging issues around COVID-19 pandemic, and including post-COVID condition, neurological issues resulting from COVID infection, detection of the virus in the wastewater, and how COVID might affect our air quality and vulnerables in our community, and also might increase the mental health concerns. And I hope you all will enjoy the symposium. During the symposium, please make sure you mute your microphone. And if you have any of the questions, please put in the, use the chat function and send a message to us. And we'll have time for a few questions after the talk and the devoted time for questions during our panel discussion. Next, I would like to introduce our keynote speaker today, Dr. Janet Diaz, who is the head of the Clinical Care WHO Health Emergency Program and since 2018. And she has worked as a lead for the clinical management team and is responsible for readiness and response to emerging infectious disease such as COVID and Ebola. And her new unit is responsible for developing the COVID living guidelines on therapeutic and clinical management and spearheading the Oxygen Access Skill Up initiative and advancing clinical research agenda around the emerging infectious disease. Dr. Diaz is a accomplished specialist in pulmonary and clinical care medicine, and also she's committed to work with the medical and public health professions to deliver the quality, safe, and cost-effective care to critically ill patients in source-limited regions. And it's a great honor to have her today, and her title of her talk is Challenges with Post-COVID Condition, WHO Perspective. Please join me in welcome Dr. Diaz.
Thank you so much. It's a pleasure to be here. I'm going to put up my slides. I did make a few to talk out of. And let's see. Is that okay?
Yes, we can see your slides.
It's okay? Okay, perfect. All right, so thank you for the kind introduction and thanks for the opportunity to be here and the invitation. I'm currently in Geneva, so it's a little bit later in my day, so I hope everyone is doing okay. And I was a little bit getting tired at the end of the day, but it was nice to hear that introduction and to be here, and it's a pleasure. As described, I'm leading here the clinical response for COVID-19, but I'm actually trained and did all my postgraduate training in the US, in San Francisco, in pulmonary critical care, and have been here doing public health work for about 5 years. So my path has been one from clinical medicine to public health, but actually in public health, working on clinical aspects of the public health response. So I'm going to share a few slides and this few perspectives. I imagine you're going to go into many details with some of the other speakers, but just to give you a flavor of the kind of work we do here at WHO and where we're sitting, how the story of post-COVID-19 condition or long COVID has evolved for us since the beginning of the pandemic. Now we're going to see if this works. I'm going to start off with some epidemiological slides, just because it's important to go through some of the basics before we start. This is a slide from my colleagues in surveillance. This was reported to the WHO as of the 17th of April of this year, with new cases of over 5.5
Janet, you're still on your title slide. It's not advancing. And you're not in presenter mode. That may be why.
Okay, I'm having issues now with my... Is that switching over?
No.
That didn't look good.
It looks like my computer's going to crash.
Something there. You're repopulating your slides now.
Oh, it's...
there we go. Okay.
You see it in a big one?
Yeah, now we can see, yes.
Okay. So I'm fixing my camera here. So you can see here cumulative cases over 502 million, cumulative deaths 6.2 million, and new deaths over 18,000. And for WHO in Geneva, we work through the regional offices system. So you can see our epi data presented by regions of the world. And it's clear that the number of cases reported and deaths are decreasing globally at this time. And here's a little bit more details as we look through the different regions, the number of cases over the last 7 days, mostly seen in Europe and the Western Pacific. You can see in the green third column, the change over the last day. So everything decreasing, the number of cumulative cases, most in Europe, in the Americas, and the Western Pacific, and the changes and the deaths occurring in the last 7 days in Europe mostly, and the Americas, and then the change that we've seen over the last 7 days. And this is just a little snapshot of the kind of presentations that we get here at WHO, trying to put together and aggregate the information that's shared with us from member states. But I work on clinical care. I don't work on counting the numbers. I actually work on making clinical management guidelines, norms, and standards, and disseminating and distributing those, and trying to get those to health workers, healthcare workers, in order to save patients' lives. And so I hope you're familiar with this. If not, please see our website. This is the COVID-19 clinical care pathway, and we've tried to simplify our guidelines, although they're written quite technically from the methodological side. But really, what is it that we're trying to do with patients who have suspected or confirmed COVID-19? Here you can see a simplified approach where confirming the infection is important, and this must be done properly and promptly, and the options there being a PCR or an antigen detecting test. Then the A is for assessment, simply assessing symptoms, risk factors, and disease severity. And we do know that early clinical assessment and evaluation really helps you to determine the kinds of interventions that patients may need that reduce mortality and improve outcome. Obviously, those with emergency signs will need to go into the emergency triage pathways. Those that have less signs of severity or no signs of severity, who we would kind of define as mild or moderate, also get treatment, but that may not be in the hospital, as we know, in the outpatient setting. And then the treatment options with R is respond with appropriate care and treatment. So here really is the treatment options that have been growing over time. We just actually published our living guideline update today with 2 new therapies that are recommended by the WHO. But really the treatment option being based on the disease severity. So we have a slew of treatments for those that are severe or critical in the hospital. That would include corticosteroids and immunomodulators such as baricitinib, JAK inhibitors, and IL-6 receptor blockers. And for the outpatient setting, now we do have antivirals, and the list of antivirals is increasing over time, but those are meant, and WHO has recommended those for those that are high-risk patients, meaning those that have high risk of getting hospitalized or progression of disease, and that the absolute benefit for those interventions would mostly be seen in that risk group. And then the E is evaluate. And this is quite important because maybe this is where we're going to be spending most of my time talking, is about the evaluation of the clinical response, both in the acute setting, but really through recovery. And I think this is where the focus of long COVID and post-COVID-19 condition is important. And here you can see we just have a little bit of not too much detail in this infographic that I'm showing you, but how important it is to monitor patients through recovery to completion or resolution of symptoms. And then, of course, if patients have prolonged or persistent symptoms, to evaluate for long COVID complications that we're seeing, as well as for interventions and care treatment plans in that patient population. So post-COVID-19 condition, the iceberg. So this is a simple slide, but I wanted to say that the early reports of infected persons with SARS-CoV-2 with persistent symptoms began early in 2020, and that was reported to WHO. There was not a surprise. I think we all knew about post-viral syndromes, and we also knew about, especially those patients who were sick in the hospital, in the ICU, that we would expect to see something similar to a post-intensive care syndrome. Initially, the studies that were done, the prospective cohort studies that were enrolling patients, and still even to this day, enrolled mostly hospitalized patients, really looking at those after discharge from an ICU to see what kind of sequelae or dysfunctional limitations those patients were experiencing. However, news also emerged within those months by the mid of 2020 that there wasn't just this prolonged symptoms or functional deficits after the acute illness weren't just being seen in patients who had been in the hospital and been very sick for a while. It was actually being seen with patients who had mild disease. And I put mild disease there in quotes because I think there was a little bit of a misunderstanding when we were labeling mild disease, and I still think there is, meaning that just because you weren't in hospital sick on oxygen or on invasive ventilator didn't mean that you weren't sick. And sickness, described by these patients were that, okay, I wasn't sick enough to be in the hospital, but I had, debilitating symptoms, be it cognitive dysfunction, fatigue, shortness of breath, and the slew of symptoms that have been described with this. But really there was a concern that, that we were not acknowledging that patients who were not being hospitalized with COVID-19, which is the vast majority of the patients we know now, is that don't require hospitalization, but that those patients indeed as well were having persistent symptoms that were burdensome and obviously impacting the quality of life. WHO engaged early with patient advocacy groups to discuss concerns as public health attention was deemed to be lacking. So we got addressed very early on by many groups saying, what are you doing for this? Why aren't you paying attention? Why aren't you saying anything? And, we had spent so much time, at the beginning of the pandemic where, we didn't have treatments, we didn't have vaccines. A lot of the hospitals were being overrun with very sick patients, and we were trying to find life-saving, reducing mortality interventions, and those that were experiencing what we now call long COVID or post-COVID-19 condition were feeling left out. especially those that weren't admitted to the hospital. So initial meetings that we had with advocacy groups really asked us to focus on three things. And this has been a little bit of the way that we have approached our work on post-COVID-19 condition. One was recognition, meaning recognize what we have. And so that means from an advocacy point of view, from a surveillance point of view, from a treatment point of view, from a health systems point of view, like this is a patient population that has an illness that needs to be defined and treated. Rehabilitation, it was early on that the group that patients called for interventions such as rehabilitation that would help them become more functional with the symptoms that they were experiencing. And then of course, research being the main thing, just like in, for COVID-19 pandemic in the beginning, how important it is to have a robust research agenda and to execute research so we can advance. And I think we've seen tremendous advancements in COVID during this pandemic and how you can do research during an emergency, which I think was something that we hadn't done very well before. We hadn't been able before much to do, large scale platform trials, large scale vaccine trials to get tools in our armamentarium in order to help stop, reduce the impact of the pandemic, stop transmission, reduce transmission, and in my case, what I focus on is improving patient outcomes. So this was quite important. However, we know still to this day that post-COVID-19 condition remains under-recognized. And though awareness is increasing, it is not increasing fast enough. And so to this day, I have regular calls with patient advocacy groups with members from all around the world to kind of get a feeling for what they're feeling as we, advance in this field, which we have advanced, but I'm also going to show you slides where it shows you where we haven't advanced, but really get a feel from them. How do they experience and how are they experiencing having long COVID in the world now? And are we doing enough? And is that getting to patients? So that's a regular meeting, actually. And I think I had the most recent one just last week with a small group of patients. I'm going to fast forward. So that's the beginning. And where are we now? And then I'm going to go through the middle part. Where are we now? We actually had a research forum on the 24th and the 25th of February this year. And please, if you're interested, go to that website. And it really describes not just clinical care, but it's actually in the multiple areas of interventions for COVID-19. What is on the research agenda now? And so I'm responsible for the work on the clinical management. A lot of it focused around acute illness, but obviously post-COVID-19 condition and long COVID is a major area of research that's still lacking and lagging behind. So in that meeting and in the report that's on this website, you can start to see what are the gaps in the questions we still have. And it looks like a lot because it may look like we haven't really advanced, although we have advanced, we haven't advanced enough. And I think that's the bottom line here. And though there has been commitment, like the US government has committed a lot of money and funds to ongoing studies now, and most recently, that still we need to, continue with that force and start to monitor as more data emerges of good quality in order to better understand and find better treatments. So natural history still remains, I think, work to be done. There are multiple observational cohort studies, and I'm not going to go through data in this presentation, but there are studies from around the world, but mostly coming from high-income countries still. And, and as WHO, we're a global organization, so we want to see things coming out of different regions in order to see, is the disease, is this illness functioning or looking like similar in the different parts of the world. Risk factors still needs to be better elucidated. There are more trials ongoing, and I know of trials in process that are trying to better understand this, but really who is at most risk and can we try to modify those risks if possible. The association with acute disease severity, again, is it the patients? Now we know that this can be seen in patients of both, of all spectrum disease severity, but is there one disease severity where we will see it the most? And I don't think the answer is clear on that. The duration of disease. So how long is this happening? What is the natural history? Again, that's when you start talking about natural history. How long does post-long COVID last? Is it 6 weeks? Is it 3 months? Is it 1 year? And we've seen a wide range of reports with that, but trying to really understand what is the average of this so that we can start to counsel our patients better and hopefully ease some anxiety and concerns around this. Differences in age groups. Again, what is this in adults? I think has been is getting better and better described, but the data in children is very limited right now. And I am aware of very few pediatric groups or pediatric cohort studies that have been reported. Regional variation I already discussed, and then of course impact by the variants. So we do know with Omicron, we saw a change in some of the clinical characterization compared to the previous Delta variant. There has been, obviously a lot of discussions about the severity of disease, but trying to understand the impact of different variants now who may be having different mechanistic or, so different approaches, different ways that they're infecting and what they're adhering to being more the lower tract or the upper tract, such as with Omicron. And how does that impact post-COVID-19 or the development of post-COVID-19 long COVID? And I still think we need to see, because we're just getting out of the big Omicron waves. And so now with follow-up, we should be able to see. The pathophysiology, I think, is kind of a key question here. And although there's a lot of smart, great research ongoing, especially of groups throughout the world, and we have been briefed by them, still some questions remain because the whole story has not yet been fully put together. But the hypothesis of viral persistence, immune dysregulation, and thrombosis, all of them there, maybe all together, maybe one more than other in certain patients or in certain phenotypes, but raising the possibility for various possibilities for various targets for interventions, which is good for us to know, right? So that we can start to do treatment studies. And I think here, treatments, what is it that we do? Is there a drug? This is a question that I'm asked very commonly. And unfortunately, I have to say, we don't have a drug for this yet, but the same thing I was saying at the beginning of COVID pandemic, when we had no evidence-based treatments for SARS-CoV-2 at the beginning, other than oxygen therapy for those that were very sick. And now, a couple, two plus years later, that we do have various treatment options. So hopefully we will see the same with long COVID, and hopefully we will see it soon. But the studies on interventions, at least pharmacological interventions and other types of interventions, are lacking still today. They're still early in the process. Finally, other aspects that may impact, one, I just talked about new treatments for long COVID, but we also have to think about what were the impacts of the therapeutics during the acute illness. And I think that's still a question that's unknown, because many of those acute illness intervention trials did not study longer term outcomes. So many of the outcomes could be mortality, maybe admission to hospital, need for invasive ventilation. So very patient important outcomes. But what was not put in many studies at the beginning, although now that's changing, and that's what we're encouraging trialists to do, is to expand study outcomes to 3 months, and not just mortality, because we want to know mortality, but we know mortality progressively is going down over the pandemic, especially amongst those that are vaccinated. And so what we want to see also is other quality of life metrics. And I'm going to discuss a little bit of what those other things can be, but we want to see things at 6 months, at 9 months, potentially to see if giving one of these treatments not only reduced mortality or reduced disease progression, but did it also reduce the incidence of the risk of developing post-COVID-19 condition. And then one of the other questions out there, obviously, is the impact of vaccination. And again, so these are still open questions. There is studies on these, and we are monitoring the evidence, but there's still, in general, things that we have not yet started to do. So we have lots to do to advance the care of patients with post-COVID-19 condition. And the only way to do this is the same way that we did it for COVID, that we are doing it for COVID-19 right now is a real global collaboration to advance the research agenda and to learn from each other and to collaborate and to share data and to aggregate. And WHO and my pleasure it's been and privilege to be at the center of a place that can bring together various and convene various experts in order to do this. So here we are. So I want to describe a little bit about how we approached this, this massive challenge that I've just described to you. And I kind of described the end with our research agenda and then the beginning of the problem. And immediately, you know, with very limited information and a real call to increase the recognition of what was going on, even if we didn't really fully understand what was going on, was a series of webinars. And so that's one way that WHO tries to bring together various experts in the field, even with very early data that may not have been validated in multiple cohorts, you know, maybe just a single center even, I think is what we were presenting at that time at the first webinar, but just to get something out, some scientific information out from cohorts around the world, even if it's limited. So we had a series of webinars, which we continue to have, and the last one was just this past March, but really the first one focusing on global cohorts on post-COVID-19 condition with cohorts presented from around the world, just describing basically what they were seeing. The second on research, which really focused on sharing the information on various potential mechanisms. And then the third one on rehabilitation. Again, rehabilitation interventions, which was, and these three were kind of based on what we had heard from patients wanting to hear about in our webinar series. And then neurology and mental health, which was most recently done, really focusing on the neurological manifestations of long COVID and also some of the mental health descriptions of long COVID and interventions. Similarly, we were even before the webinar series, because now I look at the date here, at the beginning of the 2021, we had to publish a guideline because there was no guidelines. And so we had developed two guidelines, and I hope you're familiar with them. One is the COVID-19 therapeutics living guideline. And so that really focuses just on drugs and therapeutics for acute illness, both non-severe and severe and critical. And that, again, I said, we just published a new 10th edition today. The second guideline is a clinical management guideline. And this is a more comprehensive guideline that really shows a step-by-step approach to the management of patient from triage, screening, to diagnosis, to management of symptoms through oxygen therapy, critical care management, ethics, palliative care. So it's a very comprehensive piece of work. And this was updated in early 2021 to include what we thought would be a best practice statement for patients. And like we did for COVID-19, at the end of the day, we were like, okay, we may not know everything, but we do know to tell health workers and clinicians to do the basics well. And this is what I was telling everyone before we had therapeutics for COVID-19, was we still know how to manage patients with pneumonia, severe pneumonia. We know how to give oxygen. We know how to do some of these, we know how to manage ventilators. So let us do the basics well and try to prevent any nosocomial complications or any complications from our interventions until we know better what we should be doing for this specific pathogen. So here we had a series of patients that we knew now had persistent, new or changing symptoms. And because we were getting concerns that they had no care, there was no, like, they were going to their doctors and doctors were saying, no, you have nothing, or you have minimizing the symptoms. We said, okay, maybe it's most important that we emphasize that they need access to care. And so what you'll see here is a few remarks that are very basic, but very important. So patients should be monitored for resolution of symptoms after discharge. And then if anyone has persistent or develops new or changing symptoms, they should go to their, seek medical care and get evaluated. Patients should be counseled about acute life-threatening complications such as PEs, myocardial infarctions, arrhythmias, and myopericarditis, and seek emergency care if they develop those. And now we know that this type of complications, the cardiovascular complications, have been reported within the first year post-acute illness in cohorts, especially the big cohort published out of the US, so that care of patients needs to be looking out after this. And then we had information about what we already knew about from post-intensive care syndrome, that patients should be evaluated for that and sent along a rehab pathway for those types of patients, which already existed. In the management section of this, we advocated for coordinated care pathways that include primary care, relevant specialists, multidisciplinary rehab professionals, mental health and psychosocial providers, and social care services. So even though we did not have evidence at the time that said integrated care models is an approach for this patient population, it made good best practice sense that this was the type of care patients would need because of their multi-system, heterogeneous system involvement. And so it was hard to say which doctor, if you were going to pick one specialist, would know the most for this, that right now it would be a generalist as well as relevant specialists to help support, and not just medical doctors, also other healthcare professionals, especially social care services, as we've seen the impact on people unable to go back to work. And that patients' management should be tailored to patient needs and be coordinated. Again, that's a self-care approach, that patients should be educated on self-management strategies for non-life-threatening complications, such as breathing techniques, peer-to-peer group stress management, and rehab programs as well. So this was our first iteration of a guideline with a chapter on post-COVID-19 condition. And I will have to say, we haven't updated it since because I've been waiting for more evidence to emerge, but we're currently under the updating phase of this guideline as I speak. What else did we do? We had to try to standardize a case definition. And because of the lack of information or evidence at the time, that was going to give us a scientific, I guess, or not, but evidence-based way to make a definition, to develop the definition, we decided we couldn't do that. So what we were going to do was do a Delphi consensus. And so a Delphi consensus is a way to bring around various stakeholders from around, depending on whatever thing you're trying to get consensus on. But we chose to have a consensus process with patients, people who are living with long COVID, with clinicians, with researchers from all over the world. And we did a big call out for people to participate in this survey. And this survey you can find, it's published in the Lancet, as well as on our website. And took us about, 5 months to do this. And again, so WHO, to do methodologically, to give out some product that has, that people can trust, right? Because you want to trust the product you're reading. You want to believe it was made with good methodological approach, and you want to, and that's what we kind of use with our guidelines. It's transparency and trustworthiness. So did we use a process and a method that is transparent and trustworthy? So scientifically, is that good? And then that's what we were trying to go with here. But our definition is relatively straightforward, I think. And here we were hoping by making one standard case definition, the globe could start to organize itself in how we were aggregating data from around the world, how research studies were doing, how surveillance of long COVID was happening at the national level. And so here we had patients with a history of probable or confirmed SARS-CoV-2. So we said probable because we know all patients don't always have a diagnostic test. And we didn't have a different test to do this. So we had to say probable. And that was a strong input for many people. Usually 3 months from the onset of COVID-19 symptoms. And this we got from the Delphi because it was kind of hard to start to say, when are you going to start counting that this is post-COVID versus not post-COVID, or it's just COVID taking a little bit longer to get better. So we chose to do a Delphi process, and we used some different time cutoffs, and this is what we ended up by consensus. And that lasts for at least 2 months and cannot be explained by an alternative diagnosis. So there we put a timing on it as well. How did we choose 2 months? Again, it was through the Delphi consensus. We offered different timeframes, and with a bunch of stakeholders, this is where we got with consensus, because it was hard, based on evidence, really to say what is the right number of months. Common symptoms include fatigue, shortness of breath, cognitive dysfunction. In our survey that you can find on the website, you can see the survey had over 50 symptoms, but we did not put the 200 symptoms into the survey because we know there's over 200 symptoms that have been reported. we tried to limit to the most common at the time that were being reported and just voted, had consensus on those. And the ones that appeared here aren't the only ones. These are just common ones that should very high flag. Think about this: fatigue, shortness of breath, and cognitive dysfunction. And as you start to go through the literature for long COVID, ever since since the beginning, these are the types of things that we're seeing. They generally have an impact on everyday functioning, which was another important aspect of the definition as we were going through the Delphi process. Now, what did the symptoms look like? Again, we've seen a lot of different descriptions of this. So was it new onset after the initial recovery? So that someone actually, we believe they got better and they were symptom-free, and then all of a sudden it was a new symptom? Or was it persistent from the initial illness, that the symptoms actually never really recovered? And so we left leeway there for both types, because it's hard to know from what we were seeing. And that symptoms, do they fluctuate or relapse? Meaning, do they get better? Do they go up and down, or do they actually go up, get better all the way, and then go up again? So again, because there was descriptions about the different types of symptoms, that we added all this to the Delphi, and then we came out with this as our definition. And of course, we had comments saying a separate definition may be applicable to children, and that's what we're currently working on right now as more data on children is emerging. But really important here was that a common global use of the same name and definition will increase visibility. And I didn't put a slide here about the name, but I have to say the name was also a little bit controversial, and I should have put a slide in about the name. When we came to us, the long COVID group, they came with long COVID, and that's what we have is long COVID. But I have to say, WHO had actually named the disease or the illness an ICD already in our naming group, because we have a group that just focuses on naming. And they had named it post-COVID-19 condition, and it already had an ICD code. And I know there's different names in the US that are referring to it, and there's potentially one in the UK, and you see the literature maybe different types of names, and that I think has caused confusion. I think it's caused confusion at the clinical level, at the patient level, because it is what is it that I actually have. So we have stuck with this, although people have asked us to rename. But until I feel we have a better, and it's not my decision, it's the group that works on naming and coding, until there's more data to emerge that a different name would capture the disease better, that we will remain with this one. And since it's not part of the ICD and it's getting coded this way, this is the way clinicians can also code their patient visits. So here's our case definition, and please look it in the website for more information. What else did we do? So we have a clinical data platform, and I think I'm hoping I'm starting to show you kind of the larger big picture items that WHO has been working on. This is actually a platform that started for the acute illness. And the reason we started this was to provide a standardized approach for data collection for the globe. And so there are some countries where there was already standardized data collection techniques for people who are in hospital and to collect information about clinical characterization. But that was not fully, that's not global. And you can see from the map that we still have poor penetrated areas with our data platform, but we made a CRF, a case record form, asked for standardized data collection, and and this is published on our website, but we also offered a platform, meaning an electronic data platform where we collect data. It's a REDCap platform, and countries, member states, or facilities can contribute to that anonymized patient data, and that can contribute to global analysis on clinical characterizations. So as post-long COVID, post-COVID-19 condition emerged, we had to make modules for post-COVID-19 condition. And so here's an example of our CRF and the 3 modules that are currently on our website. One that looks at the actual acute illness of COVID-19, even if it's retrospective in nature, patients who were not hospitalized. The second is the first physician encounter, which is really more based on symptoms and things that don't require any diagnostic testing. And the third on clinical examination, laboratory tests, and diagnosis. Again, a standardized way to collect data collection. So what we have tried to do with this tool at WHO is to encourage standardized data collection. Because even if you don't share it up front initially, it allows us later on to aggregate data if we're using common variables. So data sets are easier to link. And then of course, analysis can be done at a global level. So this is our CRF, and this is something that's on the website. And we also, in the electronic data platform that WHO is managing, can support member states in using that data, that type of data platform. We do trainings for member states on this. We do trainings on analysis, on developing code for analysis for countries that want to analyze their own data versus code that we will analyze at a global level. So there's also capacity building built into this mechanism. So the story continues to evolve. I just have a few more slides. What is the burden of disease? I would have to say we don't know, but I think we'll know soon. There is a group that's far advanced in doing the global burden of disease, so the group at IHME, which I think, I hope will have information soon to share with us and with the world. But we still don't really know the full global burden of disease. So just what I can say from the limited data that you are probably more aware of as well from high-income countries, approximately 10 to 20 people are reporting experiencing persistent or new onset of symptoms after 12 weeks following the SARS-CoV-2 infection. And I would say there's a little bit of a hint of similar findings with children, although I think the data there is really, really, really limited. The symptoms remain heterogeneous and multisystemic in nature, with the common ones continuing to be the common ones. Phenotypes are emerging, and I think this is important, but still need validation. The cardiovascular complications are becoming more clear. Now, how you lump in the cardiovascular complications into long COVID or post-COVID-19 condition may be a different discussion, and it may go down to mechanism of disease, but it is important to acknowledge that is being seen and needs to be monitored closely. We are seeing this disease in all disease severities, but I still think risk factors needs to be better understood, although early findings may suggest female gender, poor pre-pandemic health, asthma, and obesity are risk factors. And early studies reporting some benefit with history of vaccination or concurrent vaccination, but all that still needs to be better understood. So WHO is active in many areas. And just briefly here, I've only highlighted a couple just because to highlight what is kind of the high ticket items that are kind of soon to come out. The WHO clinical guidelines and the rehab guidelines that WHO is publishing for rehab interventions are far advanced. And we do hope to have those updated in the next couple of months, looking at clinical management interventions, as well as specifically rehab interventions. And that's being done by the rehabilitation group here at WHO in collaboration. Core outcome sets for adults. I think I described already kind of the standardized CRF, like how do you collect standardized data for post-COVID and how do you collect standardized data for acute illness for COVID. But what's also important in clinical trials for whatever intervention you're looking at is important that there is some sort of core outcome set that is being used. So again, so that trials, across trials that weren't even, they're not related in any way. But at the end, potentially, if you collect some core outcome sets, some core data as an outcome, then you can, again, it's easier to meta-analyze that data. It's easier to aggregate the data, meta-analyze it, and come out with bigger, with estimates of effect from different trials. So we are far advanced in a process with collaborators from the UK and from the US and other countries on developing the core outcome set for adults. Will come out, and I don't have a preliminary to show you, but I know it's been approved for publication in peer review, so that will soon publish. And I think the Lancet of Respiratory Medicine. The next is the case definition for children. We are working on a consensus process to adapt the case definition for children, and I think we will do it by consensus, not by formal Delphi, because there's we probably know a little bit more than we knew before. So the Delphi probably won't be that necessary, but we are going to convene a global expert group, which is how WHO tends to do its norms and standards development. We convene a global group that are non-conflicted to participate in a structured session to do the case definition. Again, this is in collaboration with multiple investigator groups from around the world. And again, I must be always grateful of all the openness of investigators and researchers and clinicians from around the world to join us in these activities. Implementation of the post-COVID-19 CRF. So we are actively trying to implement this in different countries, and we are supporting member states to do that with the hope of being able to globally aggregate data and analyze it by the end of this year to give us a better global view. Again, this is a support intervention for countries that are doing this already on their own, great, but we still hope that even those countries that do it on their own do share with us, because then we can aggregate it with a global database and able to analyze it and then publish on our website together. We have a lot of efforts into doing systematic reviews at WHO, as you can imagine, and with the breadth of publications throughout COVID-19, it's a little bit of an overload. And sometimes I get asked, how do you deal with all this? And I say it's incredibly complicated to deal with the number of studies of all different quality being published and trying to stay on top of it, especially since managing different aspects of the disease, acute illness, therapeutics, mild illness, severe illness, now post-COVID, there's a lot of things going on. So what we try to do, again, with external collaborators and researchers from all around the world in our collaborating centers, is to get help, meaning that we need to have clear questions. What is the PICO? For those of you that do guidelines. So what is the PICO? What do we want to know? What is the question? And then work with systematic review teams, methods teams that can actually do the systematic review, do the literature search. We have our own group here at WHO that does it too. We have a methods team, we have a rapid review team, we have a librarian, but for the breadth of things that are happening, we need to have many different collaborators helping us do this. So we're just talking now with different groups to do different systematic reviews to get us the data on a timely basis in a living way, right? Because everyone's talking about living guidelines so that we can move forward. Work on the global burden of disease. Again, that's a piece of work that's being done at IHME, and we are following that closely. And then, of course, convening, collaborating, and advancing together. So I think I'm at my final slide, if I may. There's a lot of people that work on this, and I kind of presented on behalf of, on behalf of myself, but with a lot of teams that are supporting us to do this work, not just within my team and unit here at WHO, but across WHO departments, across WHO regions, and with a tremendous number of collaborators, researchers, clinicians, and patients from all around the world. And I really think, as our DG, Dr. Tedros has always said, that only in solidarity can we advance, and only in solidarity can we really make impacts on people's lives and support each other and be kind to each other, because I think during this time it has been a stressful time, and the world continues to be stressful in many areas, but we can't. We have to continue moving forward, and I think it's been a privilege for me to be in this position at this time in the world. And thank you for this opportunity to share this information.
Thank you very much, Dr. Diaz. We've got a couple of questions that have come in the chat. Are you able to stay and answer a few of those? Wonderful. Sure. Let's see. Our first question has come in from students. Just a second, please.
It's around communication, and I think we've all learned from this pandemic that transparent, trustworthy communication is important. Honest communication is important. Regular communication is important. So I think what I can say from the high level at WHO, there has been a commitment here from our DG and senior management to have all those press conferences. So maybe that the press conference is it's a lot of work. You guys don't know what goes on behind the scenes for those, but to really have a consistent message that you're there, you're watching, you're listening, and you know what you don't know, and you know what you know. And in times of uncertainty, sometimes you have to acknowledge you don't know certain things, and that's okay. But you know that there's a path to get to the answer, and so you have to commit yourself to that path to get to the answer and to move the agenda forward. It gets complicated though if there's too many priorities, competing priorities, and things feel like they slow down. But I think we all try to advance a little bit every day. So I think that's what I would say is the most important, is to maintain trust in the communications.
Okay, great. Thank you very much. Our second question that comes in, this is actually a two-part question as well, is that as someone who works in emergency planning regarding infectious disease, was there any way to prepare for the scope and burden of the COVID-19 pandemic? And secondly, do you feel that the COVID-19 pandemic made us more prepared for infectious diseases and future pandemics?
So prior to COVID-19, the outbreak I had been to just that year before that year, at the beginning of that year, 2019 and 2018, was Ebola virus disease outbreak in northeast Congo, North Kivu. And I spent many months there, back and forth, going and that was a challenge in itself. And we did many things there about improving access to interventions. We conducted with the NIH was the lead, a co-lead with the National Research Institute of DRC, the PALM trial, which found 2 life-saving interventions for Ebola. So there was a lot of work that went in that outbreak, but it was limited to one province in a conflict area of DRC, but it was limited. And so it was a challenge. And were we prepared for that? Maybe a little bit, because we were able to implement an RCT quickly, which I thought was good. We were able to get investigational products there under a monitored emergency use. And we were able to have, I think, what we can say, even though the mortality continued to be high, because we had lack of community, we had issues with community trust, and that's very important, like we've already said. But we also had the deployment of the vaccine. So there was a lot of things that happened in that outbreak, but it was, at that time, it was incredibly busy. But now, in retrospect, it was nothing like what we had to experience now, and that allowed me to go to the field and be there in person and support. Now, fast forward. So were we prepared for Ebola? Maybe better than we were for West Africa, based on what we had learned in that past. Fully prepared, no, but maybe a little bit better. Should we be prepared for the next one? Yes, I think we should be better prepared. Unless we all decided to hide our eyes and pretend we learned nothing, because we have to learn from our mistakes and our successes, right? And I think we could all reflect on what those have been. One of the projects that have, I think where, we could do better next time, we had to do a lot of work for countries with limited resources, not just them, but on oxygen. So this was an intervention that we didn't think was going to be the one that was limited. There was no preparedness thinking of oxygen prior to the pandemic. Even with influenza preparedness work, there wasn't that thinking. And so here we were stuck in the first few months of the pandemic, the first part of the pandemic, with even resource-rich countries almost running out of oxygen, almost not having enough ventilators, almost not having this. And then once that happened in countries with some more limited resources, that the strain, and then that was something that we were not prepared for. So we quickly had to set up systems to do this. And I don't think, and now, so I think, yes, we are better prepared in that regard. And estimates of the tools, here at WHO, we work with the ACT Accelerator tools that are trying to help make access to therapeutics, PPE, diagnostics, these life-saving things. And as we advanced from the science side, like we found a drug, or we found a vaccine, or we found a new diagnostic test, but then you have to get it to the people, right? So there has to be a mechanism of supply chain, distribution, regulatory, cost, fair cost, transparent costing, and funding, so that it can be purchased. So this whole, if it's going to be purchased. So this whole end-to-end has to happen. And I think in pandemic preparedness, you really have to think holistically, the different types, and then end-to-end, so that whatever intervention you want to do gets to the patient.
Yeah, great. Thank you so much for all of that insight. I believe that's our only questions in the chat for Dr. Diaz. And I know you've already stayed with us quite late your time. So thank you very much. Lena?
Yeah, my pleasure. Good luck to you.
Thank you so much for such a fantastic speech and give us the WHO perspective to address this important issue, and your generosity on your time this late Friday night, actually in Geneva time. All right, thank you so much. Really appreciate it.
Thank you. Bye-bye.
Bye. All right, so next, it's my great honor to introduce our next speaker, Dr. Thomas Russell, who is the SUNY Distinguished Professor of Medicine and the Chief of the Division of Infectious Disease in Jacobs School of Medicine and Biomedical Science. His clinical and research focus is on infectious disease, and he's a practicing physician at the Buffalo VA Medical Center. Throughout the COVID pandemic, Dr. Russell has educated and informed university, healthcare provider, the public, and the business about how best to manage this evolving crisis. And Buffalo News deemed him the Buffalo Dr. Fauci. And today he will talk about COVID, where we have been and where we're going. Join me, welcome Dr. Russell.
Thank you, Lena, for that very kind introduction. So I have nothing to disclose. So this slide really summarizes, these are cases on a daily basis for most of the pandemic in Erie County. And you can see here is the beginning of the pandemic days after the first 46 cases, March 20th, 2020. Very low number of cases because we didn't have enough tests, if you all remember then. We had a quiet summer, and then we had the first holiday surge with the Alpha variant. We recovered partially from that, and about a year ago, we had the St. Paddy's Day, school break, religious holidays, Easter festivities, resulted in another peak of cases with Alpha. Cases then rapidly dropped to their lowest levels at any time in the pandemic. The pandemic was declared over by a president, which was somewhat premature because Delta reared its ugly head, which slowly increased cases over the summer and early fall. And then as we hit the cool weather, rapidly peaked, transiently went down before Omicron BA.1 hit us with a significant decrease. And now we're experiencing a bump of cases with Omicron BA.2. So if you see these number of cases here, you say, oh my gosh, it's deja vu all over again, we're in trouble. But I really think we're in pretty good shape. And that's because we've really decoupled cases with hospitalizations and severe disease. And that's due to a number of factors. It's due to the fact that compared to our earlier wave that we had back here, where we peaked at 303 hospitalizations about a year ago, and you can see the numbers for the other peaks, we've got about 70% of our population vaccinated. A lot of people were infected during the Omicron wave, which affords protection, at least in the short term. We have some therapeutics that keep people out of hospital or at high risk if started in a timely fashion. And Omicron is somewhat less virulent than the earlier variants, Alpha and Delta. Now, it's also worth noting, you can see in the slide right now, as of 2 days ago, we had 79 total hospitalizations in Erie County. Significantly less than the earlier peaks you can see here labeled for our Omicron B1 at 580. But only 31 of these admissions are actually for patients with symptomatic COVID. The rest are what we call incidental COVID. They came in for something else. We test all patients in hospital for infection control. So really, even though we're having a spike in cases, we're doing pretty well in preventing severe disease, or stated alternatively, although we still have a significant minority that's unvaccinated, our vaccines still remain somewhat imperfect against preventing infection, but they're doing a really good job preventing severe disease, hospitalizations, and deaths. And I think that this is then, whoops, let's see why I cannot advance. And I think this is, and this slide shows that the light blue bar is the hospitalizations for COVID. A significant proportion you could see is really due to incidental COVID. And so cases do not reflect severe disease in this phase of the pandemic. And this is particularly exemplified by patients in the ICU with the blue line, and the red line is those that are on ventilators. And you can see the numbers are at 9 and 3. So very small numbers here. And even some of these may be incidental. So with vaccination and prior infection, the immunity wall we're built is largely defanged Omicron, which is the good news. However, we're not out of this mess yet. There's still a lot of COVID in our community. So if you're unvaccinated, particularly if you haven't been infected with Omicron, if you are immunocompromised and haven't gotten prophylactic treatment with Evusheld, monoclonal antibodies that can protect you for 6 months, if you're eligible but not received that third booster shot, which is particularly important to really optimize protection, particularly if you're 50 and older, pregnant, or have significant underlying diseases, you're at risk still for developing severe disease and landing in hospital. So Omicron is less virulent, but is still a potentially lethal virus. These are the Erie County deaths. As you can see, we're doing better. First winter peak, that's a year ago with our sort of Easter peak. And you can see here is the Delta and combined Omicron peak, and we're down here, but there's still people dying because we have not done as well as we could in terms of vaccination. Now, how does this relate on a national and a global basis in terms of the impact of COVID? I think you could see here that in the United States, we've had nearly 1 million deaths, and likely this is a small underestimate by 10 to 20%. Contrast with the total battle deaths that we've experienced in this country, and more people have died from COVID than on the battlefield. More people have also died than the Spanish flu epidemic as well. We're at 2,742 deaths here in Erie County. You heard earlier the world estimate is 6.2 million. This is almost certainly a significant underestimation, probably threefold. There's probably been at least 18 million deaths globally during the COVID. So the toll has been significant. Vaccination and treatments are minimizing that, but the carnage is really been a once in a lifetime experience. Now, how does COVID rank to other diseases in this country? You can see here in 2021, it's the third leading cause of death. At times, in certain peaks, as the holiday peak a year ago, it passed heart disease and cancer, the number 1 and 2 leading causes of death. And so it has really been quite a significant cause of mortality. And you can see other some of your favorite medical conditions are down here, are really dwarfed by COVID, cardiac disease, and cancer. Vaccines work. I mean, you know, if the world was vaccinated, we'd be in a very different place right now. And I know we're generally heading in a good direction, but there's still, unfortunately, individuals that are at risk and dying from this disease. We're feeling good now because only a little over 300 people a day die in this country, which is somewhat of a sad state. So this is a tale of two countries that I think really brings home the importance of vaccination. So Hong Kong, maybe not a country, probably a politically incorrect statement there. You can see this Omicron peak of cases goes up here, and then the deaths followed as a slight lagging indicator. And that's largely become the most vulnerable population. The 80 and up group only had a 30% vaccination rate. And the overall population of ages 3 and older was only at 70%. So in contrast, let's look at New Zealand over here on the right panel. 100% of 75 up were fully vaccinated, 96% 12 and up were fully vaccinated, numbers that I'm extraordinarily jealous of. Omicron cases, because our vaccines are imperfect against infection, went up in very similar high fashion to Hong Kong. Deaths are almost flat. So vaccination is really our ticket out of this mess. Building immunity through vaccination is the safe way to go. Obviously, if you will develop some immunity if you get infected, but of course, then you're running the risk of having a consequence of infection, either long COVID, it was discussed earlier, and or death. In the United States, unfortunately, we still have 10% of our seniors that are not fully vaccinated, and that's 12% here in Erie County. So we are not doing as well as New Zealand, obviously, and that's why even though we're doing better, we still have some hospitalizations due to COVID, and we have some deaths. Just to get a sense in the pandemic here in the United States, This top line is the unvaccinated in terms of deaths in the Delta wave here, and then the Delta Omicron sort of hybrid wave here. This line here are people that are fully vaccinated, only 2 shots in their arms. This line is even further muted, and this data is not shown in this slide, that if you had 3 shots in your arm, you actually have a much flatter curve here as well. And so vaccines are extraordinarily protective against severe disease and deaths. And that's really what we're asking of our vaccines. I think it's unrealistic to expect we're going to be able to prevent all infections. If we could convert a potentially lethal disease to the common cold and keep people out of hospital, prevent severe disease along COVID, mission accomplished. I'll sort of skip this, but it also works against hospitalizations. This is data from the Delta area. Vaccines have worked against Alpha, Delta, and Omicron. They decrease hospitalizations, they decrease death. It's just worth noting, you can see here that the lighter blue line at the bottom is if you're boosted with that first booster, and then the slightly increase in hospitalizations if you only receive 2 shots. And so the magnitude of effect is less from 2 to 3 shots compared to unvaccinated, but it's still significant on a population basis. This translates into many, many hospitalizations and death, and therefore the importance of being up to date with your vaccines. So this is a tale of 2 states in the Omicron era, and stressing the importance of that first booster, which really decreases deaths. California and Florida had similar infection rates on a per capita basis. Florida has 6.1% more seniors than California on a per capita basis, but they had 33% more deaths, okay? And a lot of this was due to the fact that only 59% of Florida's seniors, 65 and up, had been boosted compared to California's 70%. So you think, that's not bad, only 11% difference, both did pretty well. But that 10% or 11% difference in population translates to large number of individuals that are vulnerable and increased risk. And then that translates, of course, into increased deaths or bad outcomes. In the United States, we're about 67% of our seniors are boosted. So still work to be done with the first booster. And of course, as some of you may have heard, a second booster was recently approved for 50 and up. I won't spend a lot of time on that, but you want to focus on panels C, D, and F from a recent New England Journal of Medicine paper. The control group is with 3 shots in your arm in that blue line. This orange line is if you received the 4th dose, and you can see it decreases hospitalizations, severe disease, and deaths. Now, the control group with 3 shots in their arm fortunately had a very low rate of hospitalization, severe disease, and deaths, but that 4th shot further improves on that. And so I think if you're in that category of 60 and up, particularly when there's lots of disease around and you're going to be in scenarios where you're running a risk of getting infected, I would really recommend getting that 4th booster dose, 4th shot, which is the 2nd booster dose. And for those of you who are waiting for the inevitable winter surge, which will be coming, I think there's going to be an additional booster available. And so I don't think waiting is necessarily your best strategy. I think you want to protect yourself at this time as best as possible, and then we'll deal with things as we move forward. I know booster fatigue is setting in. The holy grail is hopefully we'll get a universal coronavirus vaccine that's durable, protects against hospitalizations and deaths from all known variants, and plus those that are yet to evolve. We're not there yet, but I think we all could agree it'd be great if we get a single shot a year, maybe covers influenza, covers coronavirus, and really our goal with our vaccines is not to prevent all infections, but it's to prevent severe disease, hospitalizations, and death. And if we could do that, we'll be in good shape. But we're not there yet. So I think in the short term, we just have to accept that getting a shot every 6 months for maximal protection while we're working on these optimized vaccine formulations, I don't think is too much to ask. So COVID, as you heard from our first speaker, is not all about hospitalizations and death. Long COVID, or as NIH calls it, post-acute sequelae of COVID, is going to be the next phase of this pandemic. It's uncertain how many people have are affected by this. But with billions affected across the globe, the magnitude of this problem is going to be absolutely unprecedented. Your best strategy at this time is to maximize your protection via vaccination. So when you're infected and Omicron is extraordinarily infectious, it's going to find you. But when it does, if you have max protection, okay, the likelihood of developing long COVID hospitalization, that will be minimized. The risk is never the zero number in the age of COVID, but being up to date in vaccines is really, really going to put you from a statistical point of view in a very, very good position. So that's all I have. I apologize going over that a little quickly. I wanted to play a little time catch up. And if anyone has any questions or we could wait, I'm going to be present for the panel and we can move on. Whatever is the pleasure of people that are running this show.
Lena, should we do questions now, or would you like to hold those for the panel?
Dr. Russell, since we're running a little behind the schedule,
let's wait for the panel. Yeah, and I try to catch us up as best I can.
No, it's okay.
That makes sense.
So I'll let the audience just ask you a question. So then we have the second keynote. I'll have him to start after you. Any question? Jen, you want to start?
Sure, we have a couple of questions from the audience. Very quickly, Dr. Russo, thank you very much for that talk. First question that we had that actually came in through registration was, how can we help parents of young children who are currently feeling as if they've been forgotten? And I'm assuming that's because of the dropping of mask mandates and young children being unable to be vaccinated at this point.
Right, so 5 and under do not yet have approved vaccine. We're hoping around June 1st, give or take. So Moderna submitted that data, which looks good. So for the parents of young children, I think unfortunately it's been a long haul for you, but you want to try to make every effort to try to protect them for having them wear masks, which is a bridge to vaccination. For you to be up to date with your vaccines, because there's great data that if the other household members are optimally protected, that decreases the likelihood that other household members will get infected. And obviously now with the bump in cases, parents and children of such households where there's unvaccinated young children want to wear high quality, well-fitting masks and really be cautious. Hang in there, we're getting close to that last important group to go ahead and be eligible for vaccination.
What is the data that we're seeing right now in Erie County for young children? How are they being affected? So fortunately,
children are less likely to develop severe disease than adults, but they're not bulletproof. We've had over 1,200 pediatric deaths. If this was influenza, we say, oh my gosh, the worst flu year ever, or at least over the last 2 years. And of course, there's the MIS-C, inflammatory syndrome complications, and long COVID as well. And so, they are less likely to develop severe disease, but there's still significant consequences. And I think it's absolutely critical for us to protect our children because we don't know long-term consequences of COVID either, sort of beyond long COVID. 10, 20 years from now, where we have generations of individuals that have been infected, have premature organ failure, cardiac, neurologic, renal, etc. And so really, it's been a tough mission to protect, our young children, particularly since they were a little later in the game being eligible for vaccination and some still not, but we need to try to do the best we can for them. Right now, the Children's Hospital is relatively quiet for admissions.
That at least is great news. Thank you so much, Dr. Russo.
Of course, my pleasure.
Thank you so much, Dr. Russo. And since you were a little bit behind the schedule, and I'll skip and move my talk to the later time, I'll have our second keynote speaker to start. It's really my great honor to introduce our keynote speaker, Dr. Avanjar Nass. Dr. Nass is the clinical director of the National Institute of Neurological Disorder and Stroke and National Institute of the Health. Dr. Nass is expert in retroviral infections of the neural system and their link to the neuroinflammatory and neurodegenerative diseases. Dr. Ness has led several national and international efforts to study outbreak or neurological illness where an infectious or immune component is suspected. Since the emergence of the SARS-CoV-2, he has played a leadership role in categorizing and drawing attention to neurological complication of the infection, including testifying the Congressional Neuroscience Committee and the National Academy of the Medicine about the long-term complication of the disease. Dr. Ness's talk today is entitled Neurological Complication of COVID-19 Infection. Welcome, Dr. Ness.
Yeah, thanks very much for that very kind introduction. So let me just go ahead and share my slides here. Okay, can you see my slides? Can you hear me well?
Yes.
Wait. Oh,
yes.
Good. Okay. All right. So as you mentioned, I'm at the intramural program of the National Institutes of Health, which is located in Bethesda, which is a suburb of DC, and it's a beautiful campus. There are about 70 buildings here, and these 3 buildings in front of you over here is called Building 10 collectively, and this is the clinical center where we bring in all outpatients, and then we have an inpatient unit here, but we don't have an emergency room. So everybody who comes here comes on a research protocol for that purpose. And so my office and lab is located in the clinical center, and that allows me to see patients and do research in the lab at the same time. Okay, so one good thing about working for the federal government is you don't have any disclosures. Okay, so I want to start with this quote, and that is, Sir William Osler is considered as the father of modern medicine. And when he was the chair of internal medicine at Johns Hopkins University, he gave the keynote address to the American Medical Association in 1896 in the Carolinas. And at that time, he opened by saying that humanity has but 3 great enemies: fever, famine, and war. If he'd been alive today, he probably would have used climate change as well. And of these, by far, the greatest and far the most terrible is fever. And I think that is true because more people die of infections than they do of all the wars, famines, and things all put together. And if you look at human evolution, that's how it has taken place. You have a wave of infection that comes along, it kills huge populations. There are few remain on the planet, and they repopulate, and then comes another wave and kills people. So they are, even in today's modern medicine, where we have all the tools available to us, you can see the amount of devastation that COVID has caused. And this is just a reminder, AIDS still is around, but at the time when early in the AIDS pandemic, it caused a huge devastation of human populations around the world. And when that does happen, you get a lot of social unrest. So as you can see here, ACT UP and others, and they changed every aspect of the medicine that we follow, how we FDA approved drugs. And because of them, a lot of changes were brought to medicine. This is the picture of the Washington Mall. And in those days, every year there will be a AIDS quilt that we put out over here. And each piece of the quilt represented an individual who had died of AIDS. Okay. Eventually, the quilt became so big that it could no longer be held on the mall. So 40 years later, you have COVID, and it's the same mall here. Okay, this is at the time of Biden's inauguration. And here, this time you have flags. And each flag represented an individual who had died of AIDS. At the time of his inauguration, there were 400,000 people who had died. And currently we estimate, this is the official number, but the unofficial number is probably way over 1 million people have died in the United States of COVID. So you can see these numbers are more than doubled in a short period of time. And at the peak, there were about 4,000 deaths a day. And even now, there are close to 500 people are dying a day. I mean, we behave as though there is no COVID around, but that's truly unfortunate because in pre-COVID era, 500 people die a day, that would be big news, right? Everything would be shutting down. But now we behave as though there is absolutely no problem. And that is truly unfortunate. Nobody knows how many people have died globally. And WHO estimates just a few days ago was about 16 million, but that doesn't include data from India and some of the other countries where they're still trying to put their data together. So we don't know the numbers, but it could be way, way more than that as to how many people have actually globally died. So this is a very major pandemic of a nature of which we haven't seen in a very, very long time on this planet. If you look at all the human coronaviruses, each one of them causes neurological complications, okay, each one of them. And although we think more about SARS-CoV-2, but I think people, once these infections of pandemic nature occur, people focus on the primary organ that is involved. So here, everybody's focused on the lung and they don't really think about what's happening with the brain. Same thing when Ebola came around, everybody was focused on the GI-like illness. When I went to Liberia at that time, noticed that 50% of people were dying of meningoencephalitis, not of cholera-like illness. Same thing with the AIDS pandemic. People were all focused on immune deficiency, but a lot of them were developing neurological complications and AIDS-like dementia. And even today, the neurocognitive abnormalities are very severe. So I'm going to talk mainly about long COVID because even if the new infections are under control, what you're going to see is millions of people in this country who are going to have these long-term consequences. And we don't have the infrastructure to be able to handle it. If you look at who is developing them, so I'll show you some slides with regards to that. The definition of long COVID is not entirely clear either. So there's a WHO definition, but these definitions are not very good. I divide them into largely two categories. One is individuals who had pretty severe illness in the beginning of the infection, they required hospitalization. And then as as time goes on, some will recover completely, others do not. But that's not surprising. I mean, if you have a lot of end organ damage, some individuals were never going to get better. But this study from the UK, because they have large sample sizes of individuals through their National Health Service, shows that approximately 30% of individuals 3 months later are still complaining of some symptoms. And once you pass 3 months, you don't get better, chances that you're going to get better are actually less and less. It seems to be more in women compared to men, and that suggests that it's probably an immune-mediated phenomenon. This is a study from the Netherlands, and here they divided the population into mild, moderate, and severe. And again, it's no surprise that if you have severe infections at the beginning of the infection, you're not going to do well and long term. But even those individuals who had mild infection, and I think that's important too, that 5 months into the after post-infection, if you don't get better, you're not getting better. Okay. So this population, I think, is of major concern to us because the pathophysiology of this is going to be very different than that of those individuals who are hospitalized. So what kinds of symptoms are they actually complaining of? So you can collapse them into largely two categories if you want. The top two can be collapsed and the bottom two can be collapsed. But largely what people are complaining of is exercise intolerance, and they differentiate that from fatigue, okay? So it's not like you run a marathon and now you're just really exhausted. That's not the feeling that they describe. What they describe is they do a little bit of exercise and they just totally can't do anything at all. So I'll give you an example of a cardiologist that I talked to from New York. And what she said was that she would take one flight of stairs, and then after that, she was wiped out to whereby she couldn't even practice telemedicine any longer. And so, and this poor woman, because she was a cardiologist, she had all respiratory and cardiac workup done, and nothing that they could find that was wrong. So then patients are complaining of brain fog. What they really mean is executive function kind of problems. So there's one person who used to take minutes for Congress and at all the meetings, and she said that now she goes back and she can't really, there's a lot of information coming to her and she just can't keep it straight any longer, right? Then new onset of anxiety and depression. So they've had no history of any psychiatric disease previously. I'll give you an example of a construction worker here at NIH who was high up in the hierarchy. And this guy was in his 50s, no reason for him to be depressed, but he developed COVID. And he says after that, he just became afraid of himself. He thought he was gonna harm himself. So he checked himself up into the hospital, and he was on the psych unit for a month, after which he came out and he's doing fine now. So, and then there are individuals who develop pain syndrome. So, as well as dysautonomia, and they occur together. So a lot of autonomic dysfunction in these patients. A neurologist that I know of was practicing out of Virginia. She was an epileptologist. She had such severe dysautonomia. She was lying down in bed. She said she couldn't even sit up in order to talk to me. So they can get their postural drop in blood pressure. Their heart rate can go up, and just persistent tachycardia, or they can get pain in their extremities, so like a small fiber neuropathy. So I mentioned to you that some patients, I mean, it's no surprise if you have severe symptoms, you're going to have symptoms that persist. But there are others who have mild symptoms, they get better completely. And then there's a latent period. This latent period can be a few weeks before they develop new symptoms, and then they will persist. So if you look at the right-hand graph over here, these are patients that we brought to NIH. And you can see that, so the latent period is here in gray. You can see that several weeks after the onset of infection is when these symptoms started. 100% of them were complaining of cognitive dysfunction and exercise intolerance, okay? And then to some degree, you have all these other symptoms that they have. Okay, now there are PET scan studies that have been done in these individuals. The way the PET scan works is they get fluorodeoxyglucose. The brain uses most of the glucose. So you'll see a lot of activity in the brain, and it will outline various parts of the brain for you. So no surprise that if you look at the cortex, you're going to see increased uptake. And the way the scale works is that the brighter colors means that there's more glucose uptake, the darker colors is less. So the cortex lights up really well, and so does the basal ganglia. If you look at the COVID patients here, you can see that the cortex has less uptake, and it's throughout, more so in the front of the brain than the back of the brain. And that's where executive function really resides. So it's not like there's some infarct or something. You're just seeing global decrease in a symmetrical manner, okay, in these individuals. And this is a very fascinating study. This came out of the UK, and they, prior to COVID, they were following these thousands of patients with the serial MRI scans and neurocognitive testing. Okay, so these are healthy individuals that they were just following them along year after year with the serial evaluations, trying to see, what disease may come, and when they develop dementia, can you recognize these things pre-symptomatically or not? But then came COVID. So some of their individuals in their cohort developed COVID. Now, the advantage was that they had scans before COVID, and then they have them after COVID. So they compared them, and they have a sizable population. So about 400 individuals in each group, and their age matched. What they were able to do is they looked at the total intracranial volume. So that's the brain volume. And what they found was that here's the red line as the COVID cases. And so, they were all about the same. And then as you go along with the advanced age groups, you'll find that the volume actually decreases. So the older you are, the more loss of volume after COVID. Then they looked at various regions of the brain, and here they show you the parahippocampal gyrus. And again, the same thing, that there's more loss of volume in the parahippocampal gyrus of individuals, and more so with increasing age groups. And if you look at neurocognitive batteries, here you can see that the neurocognition is also impaired in individuals in an age-dependent manner of those that had COVID. So the implications are that if you were to follow these individuals serially, is it possible that they're going to develop the forms of dementia at an earlier age, time point than would have been in the non-COVID patients? Okay. So the question is, how is this actually happening? So is it possible that the virus is just getting in the brain and doing it? Certainly with, if you have herpes encephalitis or HIV encephalitis, the virus can be found in the brain, rabies, found in the brain, right? But so that's what we thought. So we thought that you're going to find a lot of virus in the brain. And why not? Because most of the virus is here in the nose. There's copious amounts coming out of the nose. And there's just a small little piece of bone that separates. It's called the cribriform plate. And the word cribriform means that it has lots of little holes in it. And through those holes, you have nerves and blood vessels and the like traveling. So you would say that, okay, you have virus here. It doesn't take much for it to go into the brain. Right? Turns out that actually that's not the case. The virus stays here and doesn't enter the brain. And the reason for that is what it infects are these sustentacular cells. Okay? These are support cells. It doesn't infect the olfactory nerves at all. And so if it had infected the olfactory nerves, it would have gone through the neural pathway. Actually, it doesn't infect the nerves. You lose smell because there's inflammation in the nasal mucosa, and that compromises the function of the nerves. Okay. But most people will recover their sense of smell. And here's a photomicrograph of the nasal mucosa, and you can see all these viral particles here, loads of viral particles in the nasal mucosa, right? All these small dots. In this autopsy study here from Germany, when they looked for virus, they found a lot of it in the nasal mucosa. When they went to the olfactory bulb, which is sitting right above the cribriform plate, and they found only 3 individuals with very small amounts of virus. Everybody was otherwise negative. Same thing with the olfactory tubercle. Okay, so the virus really does not enter the brain, much of it. Rarely have people detected virus in the brain, but they have. Its quantities are very, very small, and there's no pathology associated with it. So we think it's largely contaminants. We have looked very extensively with all kinds of techniques, and we have not been able to detect virus reliably within the brain. But yet, there's a lot of pathology in the brain. Okay, so the question is, why do you have all this pathology? So, now during the early part of the pandemic, getting autopsy tissue, especially from the brain, was a very, very difficult problem. But I knew very quickly at the beginning of the pandemic that unless you see the pathology, nobody's going to believe you. No matter what you say, the kinds of symptoms people develop in the brain, you really need pathology. Okay. So autopsies were not being done. Even at NIH, we didn't have the facilities. Nobody wants to cut through. The reason they don't do it is because cutting through the skull is not an easy task. You produce a lot of bone dust. And so if it's infectious, you can get infected. So you need a vacuum saw, and you need a containment, and you need a negative pressure room and all the PPE in order to remove the brain, right? So there were very few places that were able to get any kind of brain tissue. I managed to get it from the New York Medical Examiner's Office. When I called them in the beginning of the pandemic, they didn't want to do any autopsies on COVID patients. But there were a lot of homeless people that were dying. People had died on subways. People were found dead at home. So they had collected all these bodies. And the examiner told me they had 200 bodies in trucks just sitting there. And they were not doing autopsies on them. But they had actually done some autopsies on COVID patients inadvertently. They only found out after the fact that they were infected with COVID. Okay, so I managed to get about 40 such brains. We put them through the MRI scanner because we were looking for isolated lesions that could be present in the brain. And I put them through, this is an 11 Tesla scanner here, okay? So we have these high-end scanners that is almost impossible for me to get patients into because they're used for research purposes. But during COVID, everything was shut down. And they were only happy to put these brains through because if you're doing COVID research, you could actually come in and do work. If you're not, you were stuck at home. So we got this incredible anatomy here with all these blood vessels, as you can see. So these abnormal blood vessels, so we cut sections and then stained them. What I stained them were for fibrinogen. And the reason I picked fibrinogen is because that should stay in the blood vessel. It should never leak into the brain. It's a huge protein. The fact that you can see all this brown stuff around the blood vessels suggests that these blood vessels are compromised and all this fibrinogen is leaking into the brain, right? So there's huge amounts of here present in the pons. And here's the olfactory bulb. You can see huge amounts of fibrinogen. All this brown stuff is fibrinogen. Is present here in the olfactory bulb as well. But yet no virus. We looked at the blood vessels more closely, and what we found is that all these brown cells here are platelets. These are activated platelets, and they're stuck to these endothelial cells. Okay. And you can see here some small blood vessels are occluded with these activated platelets. Right? And interestingly, we find that there's a lot more in the hindbrain than it is in the forebrain. There's more pathology in the brainstem and the cerebellum. So we said, okay, there's something abnormal happening with the blood vessel. What is it? We looked for antigens. We then find viral antigens there. So then we stained them for PCAM1. This is an adhesion molecule. And so if the endothelial cells are activated, there'll be more adhesion molecules. And certainly that's what we found. On top is a control blood vessel. Here's a COVID patient. You can see this massive expression of PCAM1 on the endothelial cells. So then we said, okay, what about complement? And maybe this is an immune-mediated phenomenon. And we found that, yes, you could find, these are all formalin-fixed tissues, okay? So complement 1, 4, and 5 were present, suggesting that this is the classical cascade, or the complement cascade has been activated. And if that's the case, then we look for antibodies, and we found a lot of IgM antibodies stuck to them. So while we didn't find any of that in the control brain tissue. So it suggests to us that this is an antibody-mediated phenomenon that is causing damage to the endothelial blood vessels, that is then causing leakage of all these proteins into the brain, right? What we do not know is, what is this antibody targeting? What is the antigen? That still needs to be determined. So if these blood vessels are damaged, I told you there was fibrinogen, but what about the inflammatory cells? So we find that there's a lot of macrophages here in the perivascular space. It makes sense because if you have all these proteins, something's got to clean it up. And the macrophages are really good at cleaning out all the debris. So they come up here, but the problem with macrophages is once they get in there and they're activated, they may not leave. And these are the unwelcome guests, you know. So they stay there and they can stay activated for years sometimes. And if that's the case, then they're going to cause a lot of damage around there because they produce free radicals, they produce cytokines, and they just damage the host tissues. So you can get this chronic inflammation that can last for a long time. And you can see all these astrocytes that are activated here, no surprise. But what's surprising to us is we found very few T cells in the brain, very few T cells. If this was a viral encephalitis, what you would find is a lot of T cells in the brain, and we don't find T cells. Okay. And there's really good correlation between fibrinogen and the presence of CD68 cells, which is these macrophages, showing you that the reason they're going there in there is to clean up the fibrinogen or the serum proteins. Now, this is a study from Germany. Here they did single cell sequencing of the cells in the spinal fluid of patients who had neuro-COVID. So that's a mixed bag of patients. Some are subacute, some are chronic, okay? And what they found was there are three important observations. One is that they also found a lot of these macrophage-like cells in the CSF, very highly activated, okay? They were present in the spinal fluid. And that usually is bad news because they're very inflammatory. They found that there were decreased interferon responses and there was T cell exhaustion. So the mix of this is actually pretty bad. Okay, all three of them together. That means the innate immune responses that are targeted against the virus are not really working really well. And what you have is this activated macrophages, and they are so non-specific. They try to kill things, but they're not that good at getting rid of the infection. So because of that, what I said is, okay, let's take a look and see what's happening in the brainstem to the neurons. Okay. And as I reminded you, I told you earlier that some patients had died suddenly. And the question is, they died suddenly and they didn't have much of respiratory involvement. Was it a cardiac death or could it be a neurological death? So again, you can see this exquisite anatomy on an 11 Tesla scanner. In fact, I had to pull out an atlas to map each of these nuclei. But looking at the medulla is really good because you have these pockets of neurons that you can look at. So then I went in the microscope and looked at each of the nuclei. And what I found was there are a lot of macrophages activated around these nuclei. And in some areas, for example, here in the pre-Bartzinger nucleus, you can see these neurons look extremely atrophic, okay? And here on an H&E stain, again, you can see this neuron is atrophic and there are microglial cells around it. So this phenomenon is called neuronophagia. That means these activated microglia chew up these neurons, ultimately, okay? And this is important for controlling respiration. So if your respiratory drive is compromised, you can develop it's what is called Ondine's curse. Okay, so you forget to breathe. And you forget to breathe, you can die. So these patients can actually die in their sleep. Now, this is a study taken from the literature where they looked at neurofilament levels in the spinal fluid. And what they found was the neurofilament levels are elevated in individuals, suggesting that there is evidence of neuronal injury in patients with COVID. At the same time, what they also found was that the A beta levels are decreased. And amyloid beta, if they are decreased in the CSF, what that means is it's being accumulating within the brain. So that suggests that Alzheimer's-like pathology may be accelerated in these individuals. So I think that's been a major concern of neurologists, is that are we going to see a wave of accelerated dementia in the survivors of these patients over the next few years? And this is an interesting study here too. So this is all computer-based analysis. And what this group did was they took the SARS-CoV-2 spike protein and then docked it into all these proteins that are known to form aggregation. So the amyloid protein, prion, synuclein, and tau. And what they showed was that the docking score is really low. That means it docks really well, and it will cause aggregation of these proteins. So we can, and that's what you find in patients with Alzheimer's. You'll find amyloid and tau. Patients with Parkinson's, you find synuclein aggregates. So at least theoretically, these protein aggregation can be accelerated. There's experimental evidence for synuclein as well. This is a macaque model in which there was SARS-CoV-2 infection of the lungs. And what they found was that you can see Lewy bodies here in these neurons in the substantia nigra. So you can see that there's accumulation of Parkinson's-like pathology in these individuals. I mean, in these macaques, sorry. And this is an interesting autopsy study also, but the sample size is small. It's only 5 in each group. And they divided the population into old and young, and then looked at the cortex and the cerebellum. And what they found was, so let's look at this middle thing here. I think that's most informative. So you can see that there's phosphorylated tau accumulation, both in the cortex and the cerebellum of old individuals as well as young individuals. And they look pretty similar. So there is accumulation of tau as well as amyloid in these individuals. So that provides additional evidence that there's increased risk for development of Alzheimer's-like pathology. Well, the controls are this black bar over here. Okay. So so let me just show you what we think is the pathophysiology of these things. So you can see that there are these antibodies that are attacking the endothelium. You have leakage of these macrophages that come in. There are antibodies that could also attack some of the neurons. There's a thrombus formation that occurs, leakage of serum proteins, maybe some RBCs also. You can get microhemorrhages. And finally, you get these activated macrophages that then chew up the neurons, causing neuronal injury. So the problem with studying these things is we don't have any good animal models currently. So people have tried various kinds of things, but you have not been able to model the neurological manifestations quite yet. Generally, they've been disappointing. They have mild infections. Tools for some of these exotic animals are really not available to study. And so we really need new models to study the effects on the brain. How are you going to monitor these patients? I think you need 3 categories of markers to follow these long COVID patients. You need markers of neuronal injury. So not just the axon, which is neurofilament, but you really should be looking at other parts of the neurons. We need to look at markers of vascular injury, and then all the protein aggregation that I showed you, we need to be looking at those, and markers of immune activation. And we think that there's a lot that is immune mediated. So if you're going to do clinical trials, I would think that we should be using immune modulatory drugs for our clinical trials. So in conclusion, direct invasion of the brain by SARS-CoV-2 is rare and does not explain the neurological complications. Neuroimmune dysfunction is driven by activation of innate immunity, immune exhaustion, and antibody-mediated phenomenon. Endothelial cell damage by immune complexes is the primary pathophysiological process in neuro-COVID, and neuroinflammation may accelerate protein aggregation. So I'd like to stop over here and acknowledge a few people. So Rebecca Folkert is the New York Medical Examiner, provided us most of the brains. We got 3 brains from a neuropathologist at University of Iowa. And then Daniel Perez and Maisley are other neuropathologists who helped in interpretation of these studies. Srina and I wrote a review together in Science. And this is the group that did the pathology in my brain, in my lab. And these are my clinicians who are managing all our clinical cohorts on long COVID. This is our MRI group, and Walter is the director of our institute who provided all the support. So I'll stop here. And I can stay back for the discussion when that occurs at 3:40 if you prefer to take questions at that time.
We've had a couple of questions that have come in the chat, if we could ask you, Dr. Nath. First of all, thank you so much for that fascinating talk. I'll begin these as they have come along chronologically as you've been speaking. The first comes from Dr. David Holmes, who's the program director for global medicine in the Jacobs School of Medicine here at UB. And he asks, are there cases of long latent periods, meaning like 6 to 12 months between the end of acute COVID symptoms and the start of long COVID symptoms?
So that becomes very hard to prove, right? So the longer the duration, the harder it is to associate it with the illness. Now, if you can find the virus in these patients, then it's easier to associate. But if you don't find the virus, then you're just dependent upon immune-mediated phenomena, then it becomes extremely difficult. So although it's possible, I think proving it is going to be very hard. I mean, there are examples, for example, SSPE is a great example. Subacute sclerosing panencephalitis with measles can occur several years later, right, after infection. So certainly there's precedence for these things.
Okay, thank you. Another question from the chat that has come in, has this sort of blood vessel damage been seen in other diseases?
Oh, yes, it's quite common. Dengue causes hemorrhagic encephalitis. All the filoviruses, Ebola and others, they cause hemorrhagic encephalitis. So hemorrhagic encephalitis is seen with a variety of different types, but the reasons for that can be different in each case. Sometimes they infect the blood vessels, other times it's an immune-mediated attack. So, but yes, that can be seen in a variety of different.
Okay, and final question for now that has come in through the chat. And we'll hold some of the other ones from the audience for the panel discussion at the end. This question is there any evidence for damage to the blood-brain barrier with COVID?
Yeah, so that's what I showed you, was that, all that fibrinogen that was present in the brain at autopsy, that can only occur if there's damage to the blood-brain barrier, right?
Okay. Great, thank you for clarifying.
Otherwise, the fibrinogen should always stay inside the blood vessel, not outside. Right?
Okay, wonderful. Thank you very much. Thank you very much for that fantastic talk. Lena?
All righty. Share the screen. Jen, can you see it fine?
Yes, but you're not on presentation mode.
I'm not on presentation mode. Okay. You say notes or?
Yes, presentation mode.
Full screen?
Yes.
Okay, perfect. All righty. Good afternoon, me again, everybody. We moved around a little bit to fit everybody's schedule. So I'm Lena Mu, Associate Professor in the Department of Epidemiology and Environmental Health. I have to confess that this is really the first time my team and myself working on mental health related issue. It's all because of the COVID-19. So those negative psychological effects from infectious disease pandemic, epidemic has been observed in the past during SARS, during Ebola. However, since the COVID-19 pandemic, those massive and the long-term lockdown and social distance has never occurred before. Associated with that are the social isolation, loneliness, and people concerned about the financial damage, and also fear about the infection, whether they have access to the health care, and also infection itself, like Dr. Nass just mentioned, can also lead to the tremendous mental health concern. And because of all that, and we started the very first study at the beginning of the first lockdown in China in Wuhan in early 2020. And we enrolled about 3,000 people, adults, Chinese population over there. And then when the US started, many states started the lockdown and staying home policy, we expanded our study to the US adults, where we enrolled about 4,000 participants through the social media. And really from the last summer, some of our graduate students and also the undergraduate high schoolers have the strong interest to start a study to looking at particularly on the high school students. That's where we just starting the third study on the high school students. Those are some basic demographic informations for the first two. In this talk, I'll most focus on the US population, but I want to say for majority of the results, the Chinese population and the US generate very similar results. Those are the few mental health outcomes we measured, including anxiety, stress, depression, and PTSD. We did add a few and modifying a few when we look at the children population. We added the resilience and loneliness, and also change of some measure to the children type. So a few things among all the different results, a few things I want to bring your attention. The first one is, mental health issue really hit people very differently. When we comparing the participants across all the different age group, we find those younger population are hit the most. They're much vulnerable compared to others. Not only our study, but also many of other peer studies, and also a recent survey came out from CDC. It's a 7,000 people, 7,000 high schooler survey. Also find that more than 20% of the high schooler during the pandemic have thought about suicide, and about 9% of them attempted to suicide. It's really striking information around the mental health. And secondly, the underrepresented the population also are much more vulnerable compared to others, including Black, Hispanic, and the Native American. The third one are those comparing to the men, women are much more vulnerable across all the 4 different mental health measures. And also, as we expected, the people who have concerns about their money, the house insurance, as well as the food, as the table showing on the right, or any of those insecure, feeling of insecure associated with increased odds for anxiety, depression, stress, and PTSD. And if you look at the people who are extremely worried about money, and their anxiety level are really, really high. In addition to this, one population I want to bring your attention, and Dr. Nass mentioned that too, people who had COVID infection compared to those who did not, actually has much higher vulnerability to the mental health issues. We have very small, because our study conducted in the early 2000, so we have very few people who had the COVID infection, even though this yellow bar, you can tell across all the mental health disorders, those people who had the infection has much higher prevalence over there. And although our study is small, there's another study came out just recently came out with a giant cohort study, included 160,000 of the COVID cases who looked at after their COVID infection and how their mental health was affected. Like the figure showing here, it's very clear for those people who had the COVID infection, their anxiety, depression, stress, and even the substance use, many of the substance use, the risks are much higher, and also the sleep disorder too. So other than the, pay attention to who got hit the most, as we expected, we also find when we classify people by their behavior, whether they stayed home most of the time, or they go to the work sometime, or being isolated due to exposure, we did find a very clear trend that people who stayed home most of the time and being isolated to the exposure and suffered more from those PTSD expression, depression, and also the anxiety. I mentioned it before, most of the results from our US population and Chinese population generated are very similar. However, there's one that are different we identified, that is for the stress. In the Chinese population, we find people who experience voluntary quarantine actually in the lower stress level compared to others. So we were like really puzzled why this, well, in the US population, they're at increased risk. So then we realized when we conducted the first study in China, it was during the spring festival, around the New Year. So people were with their family, have plenty of food because the holiday, and also kids are in the winter break time. So people were relaxed and not really concerned too much about their work or academic progress. That's why we observe this very strange situation here. Then about the behavior change, I believe, including myself, or probably many of you too, experienced the behavior change during the pandemic. I changed a lot, I know. So many of those behaviors, among many of those, I want to point out two as an example: physical activity and the sleep duration. We find that people who increase their physical activity actually have a lower depression level, while people who decrease their physical activity across the board, they have the increased mental health disorder over there. And for people who change their sleep duration, either increase or decrease, and both associated with increased odds for anxiety, depression, stress, and PTSD. This is a very interesting finding. We found this also for alcohol drinking too, and in many other behavior change too. The people who maintained the stable situation had the lowest concern for the mental health, and those who had the changes in general had higher odds. The other important factor here are the social support and the family relationship. Though compared to those people who had strong social support, those ones who had poor support are much more vulnerable to anxiety, depression, and also the stress. And for people who had their experienced the family relationship change, either with parents or children or significant others, any of those, especially if the relationship getting worse, their odds ratio for the those mental health disorder are much higher. The last thing I want to bring your attention are the COVID-related media exposure. Although we do want people to understand and knowing what's going on about the COVID pandemic, too much of the media exposure certainly associated with the increasing concern on the mental health issues here. And that's something we could certainly do intervention. So we do have a lot to talk about, but I want to summarize by saying, COVID-19 pandemic really triggered overall worldwide about 25% increase in prevalence in anxiety and depression. And this is really a wake-up call for all the country. And we need to pay attention to those one to those vulnerable population, those younger generation women, and also those low-income population. We need to identify and then reduce those factors related with mental health, and also increase awareness and educate the public how we should cope with those stress. And certainly very important, as a government or country, we need to provide various levels of the mental health resources. And also you heard from Dr. Jana Diaz too, and they were trying to also implement those systematic, coordinated way to provide the mental health support in the healthcare system. Certainly, we are facing this challenge. It's a very challenging situation. One side, we have increasing needs with the pre-existing situation for the mental health and those newly developed situation. On the other side, the mental health care delivery system was significantly interrupted during the pandemic. And the other situation is the shortage of the mental health resource worldwide is a big concern. Overall, worldwide, there's only 2% of the healthcare budget was allocated to healthcare, to the mental health. And in some of the, even worse in some of the low-income countries, that only one mental health care worker among 100,000 of people that are really available for them. So as a wake-up call, we hope this get attention to the worldwide country and different level of the government do a great job to support our public health, especially on the mental health. In the end, I do want to acknowledge my colleagues on our team who worked together on those several different projects. And here, I also want to especially mention a few students who really took the leadership on those projects, are Jason Niu, Kexinju, and Yihua Yuan, and they did a tremendous work on those, and it's really amazing. And thank you all.
I think we'll hold questions for you, Dr. Mu, until the panel.
Sure. Yeah.
Should we introduce Dr. Yi?
Yes. All righty. So let's welcome our next speaker, who is Dr. Ying Ye, is assistant professor of environmental engineering in the Department of Civil and Structural Environmental Engineering at UB. And her research focused on the fate of viral pathogenesis and disease-causing biomolecules in nature and engineered system. So her talk today is tracking SARS-CoV-2 variants in municipal wastewater. Welcome, Dr. Yan.
Thank you, Lena, for the great introduction. Let me share my screen and starting. Can everyone see my screen okay? Okay, cool. Yeah, thank you. Thanks for having me. I'm really excited to share the most recent results that we got from our ongoing project about wastewater surveillance for SARS-CoV-2. Before I jump to the topic today, I just wanted to highlight my colleagues and collaborators. And this work was funded by, currently also funded by Erie County Department of Health. Dr. Ian Bradley and me were leading the projects. We're from the Department of Civil, Structural, and Environment Engineering. We're a wastewater guy. And we are collaborating with the sewage management. Joe Figo is our old friend, and then he helped to coordinating the sample collection from different wastewater treatment plants in Erie County. We also collaborating with UB Genomics and Bioinformatics Core, Dr. Jennifer Sutis, and then many other great scientists there. We're doing wastewater genomic sequencing work. And for us, if you're interested to know like what's going on in our wastewater, we have this great panel website. You can visit there to see the levels of SARS-CoV-2 genes in the wastewater, and also showing the cases in our county. For me today, I wanted to talk more focus about this variance detection. We are using the whole genome sequencing of SARS-CoV-2 to understanding what's the different percentage of different variants in our wastewater. I want to highlight that my students, Chongling, Emily, and Vicky and Ganya, they put most of the efforts on this project. So let me go back to the wastewater-based epidemiology. So why wastewater can be used to tracking the SARS-CoV-2. So this technology is developed based on the fact that the infected individual by the COVID-19, they can shed the SARS-CoV-2 genes in their feces. So this figure showing not just in the sputum, related with saliva, those samples, those viruses can also, the genes can also be detected in the stool samples. And you can see the gray dots, some of the gray dots really showing really high concentration of the RNA copies. And when the patient, when the infected individuals can be symptomatic or asymptomatic, everyone they gonna go to will have go to using the toilets, and when we were flushing, and those genes and those viral particles can get into our sewer systems. Like in theory, the wastewater should collect all the SARS-CoV-2 genes that shed from all infected individuals, which we call in the sewer sheds, the areas where the wastewater collected. So instead of testing individual persons, we can just go to the wastewater treatment plant and grab the influent and to looking at what's the level of SARS-CoV-2 genes in there. Recently, there's several studies. People are measuring the gene levels and reporting how that correlated with the cases. One study really reported really sensitive, so they can test in one positive case per 100K residents. And I have to point out that the SARS-CoV-2, I keep saying it's genes because no studies that ever reported say they found infectious SARS-CoV-2 viruses in the wastewater. So typically we're just assuming the SARS-CoV-2 gets inactivated in the wastewater, and so that we can still doing the wastewater testing and in just a biosafety level 2 lab. Okay, and then, okay, so with the, so right now, we are more concerning about different variants circulating in the community. So like we want to know what variants being detected and what's the percentage of different variants circulating in our community. So that's, I would introduce in our work to doing the variance detection. At this point, PCR assays are the most widely used for detecting the variants. So for the PCR assays, what they're doing is to design specific assay that targeting a small section of genes on the genome that where the mutations can be that are more frequently observed on the genome of the certain variants. For example, the alpha variants, we're just detecting those deleting mutation at the 69 and 70 location to looking at that specific genes as a signal for alpha. But using the PCR, in order to knowing what's the relative honest of this variance, we will need another assay, which CDC recommended N-gene assays to give a total SARS-CoV-2 genes in a wastewater. So which says, even though PCR is really sensitive and really fast assay, but as you can see that if we wanted to detect more variants, we will develop a lot of assays and to doing a lot of assays per sample, which can significantly increase the cost of supplies and labors. And also developing the assays needs time and needs several rounds of validation. So what we want to do is to maybe thinking another way to do that is to doing the sequencing. So if we can sequencing the whole genome of SARS-CoV-2 from the wastewater, and then we can combining different bioinformatic tools to do the to estimating the different percentage of variance in our wastewater sample. So in order to do the sequencing, we pull out a few studies and to looking at how their results look like. So there are definitely a lot of challenges. So the first one is the SARS-CoV-2 gene in wastewater are really, really diluted. So it's about 10 to the 6 gene copies per liter, which is I give you the highest amount number. Typically, it's around 10 to the 4th gene copies per liter to 10 to the 5th gene copies per liter in the wastewater. And these studies, they're using a bunch of different assays to concentrating the SARS-CoV-2 genes in the wastewater. As you can see here, some studies using the AMICON, which is the ultrafilter, the spin units, to concentrating the viral genes in the wastewater, and some are using the column or silica method, and also some method using the aluminum hydroxide precipitation. But you can see here, we're plotting the sequence breadth of coverage as a y-axis. So the 100% or close to 100% is what we want. The axis is showing the CT value. Smaller the CT means higher amounts of genes in the sample, and larger CT means smaller amounts of genes. But you can see that these dots just everywhere, suggesting that the success rates can be random. Like sometimes even when you have very high level of genes, you can still fail the sequencing, get really low sequence coverage. So these data suggesting that simply concentrating the SARS-CoV-2 genes from wastewater is not enough. We need to thinking of a way to improve the success rates, and also to thinking what's going on in our samples. So what we were focusing is to thinking the quality of the viral genome. So the quality, I mean, the presence of other non-viral gene, which can probably inhibiting or interfering the sequencing assay. So wastewater is really complex matrix. So not only like we're shedding and then flushing the toilet, the feces or the gut microbiomes getting into our system, we also have other compounds and molecules gets into the wastewater, like pharmaceuticals and other detergents when we do the laundry, a lot of personal care products, even the garbage, because the wastewater also collecting the rainwater, the stormwater runoff from the city, definitely will getting soils into the wastewater. There are a lot of humic and fulvic acids, and there are some chloride and also heavy metals gets into the system. So wastewater is a really complex matrix. So for our goal, we wanted to develop a wastewater processing for recovering high quantity, but also high quality genomes from wastewater. And then we're gonna apply this wastewater genomic sequencing to tracking the SARS-CoV-2 variants in the local sewer sheds. So we designed this workflow in order to enrich and also purify the viral particles from the raw wastewater. Okay, we're starting with about 100 milliliter wastewater. And the first step is to do the 10,000 G centrifugation. We remove the solids, also removing other prokaryotes, eukaryotes, and other solids from the wastewater. And then we do the ultrafiltration method with the 30 kilodalton membrane. So virus greater than 30 kilodalton. So we concentrating the virus while removing other molecules that are less 30 kilodalton. And the last step, when we decreasing the volume, and the last step, we're doing the ultracentrifugation. We're pelleting the viruses. And so the virus are pelleted, so we can removing the solids, removing those soluble proteins or nucleic acids in the liquid. And then we resuspended our pellets in the buffer solution. The downstream work is including the RNA extraction and then do the whole genome sequencing work, follow the ARTIC protocol. This work was, genome sequencing was done in our lab, genome extraction was done in our lab, and then sequencing was done in our proteomics core, in our sequencing core. And I want to highlight this ultrafiltration system. Instead of using those Amicon spin filter, we developed this tangential flow filtration system. We using the multiple head pump so that we can processing 4 samples at a time. And this tangential flow, is better than those Amicon filter because the tangential would reduce the membrane fouling. Because wastewater, even though we remove the solids, there's still a lot of unknown stuff in there can block the membrane easily. So, but using the tangential greatly reduce the membrane fouling. And then we're also using the sodium hydroxide to cleaning the membrane so that we can reuse the membrane for multiple runs of processing. The wastewater we were collecting, so this is kind of try to do a pilot study. So we're focusing this 4 sewer sheds in the Erie County. We pick up this 4 sewer sheds because we have a variety of different estimated population, and their flow rate are quite different, so that we can test things to see if our methods are able to handling different sewer sheds and the size of different sewer sheds. So we're starting the collection from the November 2021, and so the data, we're still working on this, but the data I'm showing you today is from the November last year to March this year. We did weekly sampling, so 1 sample per week, and we collecting 24-hour composite samples, which means the wastewater is like every hour we're collecting a little bit wastewater, and then we combine it 24-hour liquids together. Okay, now I'm going to show you some of our results. Here we're plotting the sequence breadth of coverage versus the CT value. Also, I listed 2 different other methods. I just show you in the previous slides to see the improvements in our methods. So for the blue dots is our methods. So you can see that we definitely improving the success rates. We have less points kind of scattering at lower range of sequence coverage. But overall, our methods can help improve the sequence coverage, which line over here around 100%. And these lines I did a logistic estimation like about the success rates. So you can reading from the y-axis on the right. The success rate I define as if we can get greater than 90% breadth of coverage. For our method, it definitely helped to improving the methods that you can see around CT32. We can get really high sequence breadth coverage, and the success rates is way higher than the other methods. But I have to say we only showed 72 samples. So we wanted to add in more samples to see how our methods, this curve gonna changing with more samples. And so here's another plot because we wanted to see how sensitive our methods can be applied to pull out full or near complete genome from the wastewater at very low incidence rate. So this plot is the y-axis is a sequence breadth of coverage, and the y-axis showing we go to each sewer shed and did 7-day average incidence rate, and to plot that versus the sequence breadth of coverage. So as you can see here, I think I would say about 30 cases per 100K people, and we can get a really good reproducibility of this, really good full genome coverage around full genome coverage for our samples. But down 30, because they're little, very small amounts of SARS-CoV-2 genes in the wastewater, so that will make the sequencing more challenging. But I have to say the tangential flow gave us really flexible concentrating volume. So right now we're just doing about 100 milliliters. We were thinking to do maybe 250 milliliter to see if we can improving the sequence coverage at the really low incidence rate. Okay, so putting the data together, here I'm going to show you what's going on from November to January, kind of prove a concept. I think everyone knows that it's Omicron takeover, but I just wanted to show you that's what we observed from the wastewater. I'm not showing the January and I'm not showing the February, March data because those months we had really low cases. We're still figuring out the bioinformatic analysis to see what is the best way to interpret those data. And I want to highlight our collaborators at the UB Genomics Bioinformatics Core, especially Jonathan and Nadali. They do most of the bioinformatic analysis. Okay, so here, first, I'm showing the Delta Omicron, and this is the data about New York State. We're still waiting the Erie County data, but here, what I can easily pull out is the New York State percentage changing different variants. So you can see that here, early December, Omicron starts showing and then quickly take over around January. And our wastewater, I will show different sewer sheds, and then the bars representing the different colors represent different variants. So in our sewer sheds, we found very similar trending that Omicron starting to show. We see a little bit Omicron around December, the second week of December in the Erie County's wastewater. And then the third week of the December, we saw significantly increasing of the red bars suggesting the Omicron starting in our community. And in January, we saw most of the samples we analyzed, we found that's the Omicron. So this, I want just quick conclude our study. So definitely this tangential flow help to purify the viral nucleic acids from wastewater so that improve our success rate to get the whole genome sequence of SARS-CoV-2 from the wastewater. And based on our kind of pilot study, we showed that we can use in the wastewater to have a quick estimation of what is the relative abundance of different SARS-CoV-2 variants circulating in the community. And I think we'll get a better idea when we got the Erie County data. The last I want to say, here we recovered, so sequencing, whole genome sequencing data, we can really get a good quality of data down to K residents. So for future work, we wanted to better understanding our bioinformatic analysis and how the different sequence breadth and depth were affecting the estimation of different lineages of variants in the wastewater. And then we do the data, clinical data and wastewater data comparison with the Erie County. And because this workflow is not really specifically designed for SARS-CoV-2, the tangential flow concentrating. So the system can be adapted and used for concentrating other viruses like respiratory or respiratory syncytial virus or influenza virus, which there's a few studies reported they detected genes in the wastewater of those viruses as well. And we can also do other concerning enteroviruses like HepA as well. So wastewater-based epidemiology, we're just trying to looking for more information that we can extract it from the wastewater. Okay, so last I want to highlight, this is my group. highlighted my students, and Emily and Cholene and Vicky, they do spend most of their time on this project. And this figure, great figure, this is Dr. Bradley's master students. She is running, set up this tangential flow in a lab. And at the end, I want to highlight again my colleagues and then collaborators, our funding source. With that, I don't know if I have time to take questions, but yeah, thank you.
Thank you so much, Dr. Yeah. So we'll not do the question at this moment. We'll leave it to the end when we have the panel discussion. Is that okay?
Yeah, sure.
All right. Okay. So next, our speaker is Dr. Meng Wang, who is assistant professor in our Department of Epidemiology Environmental Health at UB School of Public Health and Health Professions. And his research really mostly focused on environmental exposure monitoring, air pollution modeling, and health impact of the environmental exposure, especially his interest in producing accurate human exposure estimate for health studies using advanced exposure technology analysis approaches. And today his talk is Clean Air and COVID Pandemic and Opportunity for Radical Changes. Dr. Wang?
Yeah, thank you, Lina. So let me share my screen. Okay, so can you see it?
Yes, you're just not in presentation mode.
Okay, how about it now? Okay, so hello everyone. So it's my great pleasure to present my the work in the annual Global Health Day Symposium. So today my presentation is really focusing on the overview of air pollution effects on coronavirus diseases and trying to understand how the pandemic will have impact on air quality in our world. So let me first give a short background introduction about air pollution. So as we know, air pollution now is a very important risk factor, which causes millions of people dies each year. And globally, we can see that about more than 20% of the deaths could be attributed to air pollution. And of course, air pollution, in fact, is dominant to cause COPD deaths, which contributed to 40% of these total deaths. And if we look at air pollution effect by age groups, so you can actually see that the elderly who are aged more than 65 years old are especially susceptible to air pollution. And now we are moving forward to the post-COVID pandemic period. And until now, based on the Johns Hopkins report, you can see that about 500 million people has been affected by COVID-19 diseases globally, and more than 6 million people died because of COVID-19 diseases. And among this population, we can also see that if we look at the COVID-related hospitalization, ICU admission, and the case fatality. So you can also see that the major impact of COVID-19 diseases is for the elderly groups aged older than 65 years old. So this group of people overlapped with those who are also susceptible to air pollution. And this makes us to ask the question about whether air pollution effect may play an important role in the COVID-19 case fatality. And if so, what are the underlying mechanisms behind it? So I did a quick research on PubMed and actually find that many researchers are quite interested in this topic on air pollution and COVID-19 diseases. So in 2020, you can see that more than 300 publications focusing on this area, and the number is doubled in 2021 and keep growing in 2022. So among the number of these studies focusing on air pollution and COVID-19 diseases, I would like to highlight one study conducted in the United States, which is done from the researchers in Emory University. So in this study, we know that in the United States, we have very well tracked case numbers for COVID-19 diseases. So this group, they utilized these resources and calculated the COVID-19 case fatality, which is the number of deaths, COVID deaths divided by the confirmed cases, and also the mortality rate in United States. Then they also have this well-established air pollution exposure model to predict PM2.5 and NO2 concentrations nationwide in the United States in the same period. So this allows to link the air pollution exposure data with the COVID-19 case fatality and mortality data. And in what they found in this study is that you can see that they found an interquartile range increase in NO2 concentration is strongly and consistently associated with higher risk of COVID case fatality, about more than about 10% higher risk in this outcome, and also about 15% increase in COVID-19 mortality. And because NO2 or oxides of nitrogen is an important indicator of traffic emission. So this study actually highlighted the importance of traffic-related pollution that may play an important role in worsening COVID-19 diseases. And of course, there are also some other studies conducted in United States and find some evidence of other air pollutants like PM2.5 with COVID-19 diseases. So what are the underlying pathways between air pollution and COVID-19? So from this graph, we can see that COVID-19 may cause a number of symptoms and diseases, including cardiovascular disease, respiratory disease, and etc. And some of these diseases may also share the same pathway of air pollution. For example, stroke, acute coronary syndrome, and heart failure. So it is possible that air pollution may cause coronavirus diseases both acutely and chronically. So there's a hypothesis that one hypothesis is that for short-term exposure to air pollution, it is possible that air pollution may typically affecting people with existing coronavirus diseases and by change their immune system and then cause and leading to the consequent severity of these disease symptoms. And on the other hand, for long-term exposure to air pollution exposure, so air pollution may affecting people by reducing their immune system and other biological changes, making them more easily of catching COVID-19 diseases and furthermore worsening their symptoms. So there's kind of two different pathways of air pollution may affecting this coronavirus diseases. However, or even though we can see that there are some evidence that air pollution may be associated with coronavirus diseases, but it is also worth noting that air pollution concentration has been reduced dramatically in the past decades. So this is a trend from the US EPA report where you can see that PM2.5 concentration has been reduced by 40% and NO2 reduced by 60%. But you can also see that the declining trend is becoming even smaller or slower and flattening out. And this is because that reducing the fossil fuel combustions to improve air quality is becoming very challenging. But on the other hand, what we can see here is that large epidemiological study has found that strong association between PM2.5 exposure and mortality in elderly population. And this if you look at this concentration response curve, you can see that the association remains exist even when the air pollution concentration is below the safety level recommended by the US EPA. So this actually come up this question that how and whether we can reduce air pollution even further in United States to protect humans' health. But so far, we have no evidence or no approach to see how lower we can reach to reduce air pollution. And actually, the COVID pandemic giving us a very unique opportunity because many cities and countries has launched the city lockdown policies with the aim to reduce the spread or the transmission of the disease, COVID-19 diseases. And the study has looking at, and we can see that during the city lockdown, there's a number of policies released to reduce this dispersion. And one study investigates whether the effectiveness of different policies to reduce this transmission. And they find that the top 7 most effective approach is really related to constrain people's human behaviors, such as by canceling small gathering in public locations and encouraging people to work remotely instead of in person, as well as to close the boundaries between the countries. So most substantial change of human behaviors actually has significant impact on our environment. Typically in the United States, we have known that about more than 40% of air pollution sources came from traffic emissions. So if we can reduce these human behaviors, it is possible that the source of emissions could be substantially reduced. So our group, my colleagues at Yale University and our group have conducted one of the first study to look at the impact of city lockdown on air quality and health. So we focused on the Wuhan city, which is the city where the COVID outbreak happened, or the earliest COVID-19 disease outbreak happened. And during that period, you can see that the city has launched the city lockdown policy, which means that people cannot go out and many traffic has been rigorously restricted and no traffic coming to the city or go out of the city. And this intervention takes about 1 month. And we use the satellite data to really clearly showing the difference between the NO2 concentration before the city lockdown and during the city lockdown. So you can see that the yellow color or red color, which indicate a high concentration of NO2, has been significantly reduced during this period. And this trend is actually matched very well with the observational data we have observed from the air monitoring stations in the same locations. And by converting this reduction of air pollution to the health benefit, we can actually see that for NO2, there will be about 9,000 population deaths could be avoided because of the improvement of air quality in Wuhan during that period. And of course, our study is a local study, but other studies also have focusing on more regional changes of air pollution or global change of air pollution. And this is a satellite data which compares the NO2 concentration during the city lockdown period versus the same period in the previous years. So that's in United States, Europe, and China. So you can see consistently that the air pollution concentration has been reduced during the city lockdown period as compared to the previous year. And if we do some calculations, you can see that there's a study that looking at how much change of air pollution in the city during the city lockdown period versus the the same period before the 2020 across 34 countries. So an interesting finding is that for NO2, you can see that there's dramatic decline in concentrations during the city lockdown period. So most countries has more than 50% of these reductions. And by linking this air pollution decline with the human mobility data observed based on the like the Apple and app or the Google apps, so they actually find a very strong linear relationship. So which suggests that it is possible to reduce NO2 or oxides of nitrogen concentrations by simply constraining people's movement and reducing human man-made emissions. But on the other hand, they also find that the decline the decline for PM2.5 is actually much smaller, and some countries even get observed, also get a higher increased concentration. And for ozone, which is secondary pollutant, that actually the concentrations are increased during the pandemic period. So this is actually kind of sad news to us, because this actually illustrated that even if we make a full effort to reduce the man-made emissions, it is still not possible to really solve the air pollution problem for PM2.5 and ozone. So what we can do really to reduce the concentration for PM2.5 and ozone, I think the good approach we should do is still to stick to the carbon neutrality strategy, which is a strategy to fight for the climate change. The reason or the rationale behind it is because if you look at this chart, you can see that the emission source for greenhouse gases actually shared the same pathway of PM2.5 emissions. So this means that if we can reduce the greenhouse gases, it is possible that we can control PM2.5 concentrations even further. But this reduction is not simply to reduce the emissions directly from man-made sources. It is really encourage us to use more innovative ways, such as the energy system transformation approaches, like the vehicle electrification or clean energy transition. These strategies to achieve these goals. So one study conducted in the California, they have estimated that if we can really achieve the net zero greenhouse gases emission by 2050, which is the promised deadline for the United States to achieve this goal. So it is possible that PM2.5 concentration can be reduced by 5 micrograms per cubic meter at that time. So this is actually a very big number, because nowadays the average concentration of PM2.5 in the United States is already below 10 micrograms per cubic meter. Okay, so I will make a conclusion for my presentation. So now we can see that traffic air pollution can from this study, we can see that traffic air pollution may enhance the susceptibility to severe COVID-19 outcomes. And on the other hand, during the pandemic, we can also see that the city lockdown may also dramatically reduce traffic-related air pollution, such as oxides of nitrogen. So this suggests that there's maybe some benefit to reduce air pollution and improve people's health for the non-communicable diseases. But on the other hand, we can also see that PM2.5 and ozone is hard to reduce even we have rigorous control on the emissions. So if we want to really reduce air pollution, we really need to stick to the joint mitigation strategy to control both air pollution and greenhouse gases to maximize air quality and public health, which we call the core health benefit. And the last but not least, I just want to highlight this news that in 2021, the WHO actually launched the new air pollution guideline. And if you see this new column, you can see that air pollution, especially PM2.5, ozone, and NO2 has been recommended concentration has been dramatically reduced. So this means that this information may be captured by this pandemic period, but also giving us this critical thinking that if we want to achieve this goal, we need to really learn something from the pandemic period to really achieve this low concentration. So that's all for my presentation. And if you have any questions, please feel free to reach me out. Thank you.
Thank you very much, Dr. Wang. Jen, can you bring back all the panelists? Then we can.
Absolutely. Panelists, if you wouldn't mind turning your video back on. Thank you very much. Okay. Thank you very much, everyone, for excellent talks. We've got questions for all of you, actually, from the chat and some questions that were submitted prior to the event. So let's start again with Dr. Nath. We have a question from actually one of our speakers. I don't know if he is still here with us, Dr. Tom Russo. So apologies if this was covered already, but he asks if any CNS-specific autoantibodies have been identified.
So yes, there have been some work done. Michael Wilson at UCSF has looked at some of these things, and they basically took some rat brain and put spinal fluid on there and showed that there are some cross-reactive antibodies. To the best of my knowledge, they haven't identified what the antigens really are. Now, there are some other subset of individuals who had developed known autoimmune syndromes in the setting of COVID. So those that anti-NMDA receptor antibodies or limbic encephalitis. And so those, I think, just get triggered by an infectious process. There is another guy in Arkansas, he's a nephrologist. He identified antibodies to ACE2 receptor. And so we are eager to see if that could be important in CNS-mediated blood-brain barrier breakdown, because ACE2 receptor is present on the endothelial cells. So that's the best I know.
Okay, great. Thank you very much. Dr. Ye, we'll turn to you right now. Question for your presentation on COVID and wastewater. Have you done electron microscope examination of your pelleted viruses from wastewater? And are they still enclosed in a nucleocapsid that protects the RNA?
That's a great question. So I also wanted to know whether what the integrity of the SARS-CoV-2 in the wastewater look like. No, we haven't done the electron examination because I think for our methods, we're concentrating all viruses in the wastewater in theory. So 90% of viruses in wastewater, they're bacteriophages. So I feel like if I just using our samples, we probably just see tons of phages. It's hard to find the SARS-CoV-2. If there is any like really specific SARS-CoV-2 trapping method, pull out the SARS-CoV-2 from wastewater, I think that was doing the electron. I heard echo. Electron microscopic examination. Yeah.
Thank you very much. we'll move to Dr. Wong very quickly. Dr. Wong, why do you think it is that we see decreases in some of the pollutants and yet increases in some situations in another?
Yeah, this is a good question. So I think there's some background behind air pollution chemistry. So we know that you can see that NO2 concentration has been reduced quite a lot. That is because NO2 is directly emitted from fossil fuel combustions, like traffic emissions and industry emissions. So it's simple that when people don't emit these sources, it's possible that this concentration has been reduced. But for PM2.5 and ozone, that's more complicated. On one hand, I would like to say that ozone is a secondary pollutant, which means that it's not formed directly from the produced by human emissions. So it's basically the product from the primary pollutant. So some pollutant may increase the concentration of ozone, but some of them may also clean it up. So, for example, the nitrogen monoxide, which is also like the traffic emission source, and this pollutant typically clean up ozone. So we can see low concentration along roadside, low concentration of ozone along the roadside. That's because the contribution of NO. So because this emission source has been reduced, so it's possible that this source, these precursors do not contribute to the decline of ozone, and in other words, ozone concentration increase. And that's the same story for PM2.5, because PM2.5 is more complicated, both from primary source and secondary sources. So it's possible that it's harder to control these two complicated pollutants.
Okay, great. Thank you very much for the clarification on that. We'll go back to Dr. Nath for a minute before we talk to Dr. Mu, because their questions are sort of related, and then we'll have a question for everybody. Dr. Nath, the COVID pandemic has been called in various media a mass disabling event. Would you agree that that's an appropriate characterization? And if so, how should that change our public health approaches to it?
So I think you're right. I mean, if there is that huge population of so-called long COVID that's going to be a disabled population, then I guess the term in some way describes that, right? The problem with these patients is that there's not much objectively that you can find on exam. And so they go to physician to physician, and there's not much that they know what to do with them. So, and they cannot, it's also hard for them to get to see specialists. They have, 6-9 months waiting list before they can get in someplace. So we have a huge problem on our hands currently. Some universities are putting together, multidisciplinary clinics for them and such, but even then people can't get in. So I think it's a huge public health problem, and we really need to find some solution on how to handle them. And we need to do clinical studies and trials on these individuals, on a rapid basis. We can't wait to understand the pathophysiology before we intervene. I think we've got to intervene. And this is reminiscent of chronic fatigue syndrome, post-Lyme syndrome, Gulf War syndrome. We've had a bunch of these, and they look quite similar to one another. And we've never been able to resolve any of those. So here you have a clear infectious agent, and you have the same public health crisis. So I think we need to really put our minds together and come up with a better solution.
I agree very much. It's a crisis in the making, or an ongoing crisis. So thank you for that statement. It relates somewhat to a question for Dr. Mu, of course, as mental illness is often called an invisible illness or an invisible disability. Dr. Mu, is there anything you can suggest for better public health messaging to reduce the impact on mental health?
Yeah, I think certainly probably the first step is we really need to increase the awareness of the mental health issue around our community, and especially around those vulnerable population. And I want to point out here again, about those young generation, the teenagers who suffer the most, and they're also probably the one didn't seek for help and didn't know how to talk to others about their issue. So I'm guessing many of those message, public need to be educated, and those messages need to be delivered through various channels. Using the teenager as an example again, through the school, through the our parents, and also the healthcare provider. I was very happy to, when I visited the clinic, I saw that actually in the healthcare provider, they start to do the screening of those mental health issues. That was very encouraging for me. We're trying to do this coordinated way and also trying to deliver the message. And also we need to make sure people know whether are those resources available for them to seek for help if they need it. I think those are very important things to take care of.
Wonderful. Thank you, Dr. Mu. I'm cognizant of our time here today, and especially of our speakers' time, who have generously given us their afternoon today. So I'll hand it over. I know people have a lot of questions, still really fascinating talks. I thank you both, and I'll hand it over to Dr. Mu now.
Okay, thank you, Jan, very much. I want to thank you all our speakers, Dr. Diaz, Dr. Russell, Dr. Ness, and Dr. Ye and Dr. Wang, for really providing us very insightful information on those critical global health issues. We also want to thank you, UB's community for global health equity and global medical program in Jacobs School of Medicine and Biomedical Science for co-sponsoring the event. Finally, we want to thank Jennifer, Dr. Jennifer Foster from our office organizing the event, and Dr. David Holmes too for helping facilitate the symposium. And also want to thank our staff person, Karen, Miranda, and Janelle for helping promote the event. And for our audience too, thank you all for attending, and hope you all have a wonderful weekend. And thank you all. Thank you so much, Dr. Ness, Dr. Wang.
Thank you.
It was so nice to meet you.
Likewise.